This morning is our third and final day of the June ACIP meeting. We're going to take attendance of the ACIP members and the ex officios. Voting members, please say your name and if you have any conflicts of interest. Dr. Brooks.
Oliver Brooks, no conflicts.
Dr. Chen.
Good morning. Wilbur Chen, no conflicts.
Dr. Sineas.
Sybil Sineas, no conflicts.
Dr. Daly.
Matt Daly, no conflicts.
Dr. Jameson.
Denise Jameson, no conflicts.
Dr. Cotton.
Good morning, Camille Cotton, no conflicts.
Dr. Lair.
Jamie Lair, no conflicts.
Dr. Long.
Good morning, Sarah Long, no conflict.
Dr. Maldonado.
Good morning, Yvonne Maldonado, Stanford PI for the pediatric COVID vaccine and RSV vaccine trials and adult varicella vaccine trials.
Dr. Schechter.
Rob Schechter, no conflicts.
Dr. Shaw.
Al Shaw, no conflicts.
And I'm Kip Talbot, and I have no conflicts. Our colleagues at the Centers for Medicare and Medicaid Services. Dr. Hance. Dr. Kaslow from the FDA.
David Kaslow, good morning.
Good morning. Health Resources and Services Administration.
Sareed Grimes, representing HRSA. Good morning.
Good morning. IHS.
Good morning. Matthew Clark, representing IHS.
National Institutes of Health.
Good morning. John Bible, representing the National Institutes of Health.
Office of Infectious Diseases and HIV. Okay, one more time, I'm going to try CMS.
Good morning, this is Mary Beth Hance. Apologies for not speaking up before.
You're fine, thank you, good morning. And Office of Infectious Diseases and HIV/AIDS Policy. Okay, we're going to move forward. This is good news and bad news for us. Next slide. We have some members that are leaving us today, and this is difficult. This is incredibly difficult because we have done more than our fair share of meetings, and I'm ever so grateful for the work that these four have done. Next slide. I just have to say, Dr. Chen, we are so appreciative of your knowledge of all of these travel. I'm trying to think of the word when a critter does it. Vector. Sorry, vector-borne. You will be missed. You're incredibly thoughtful. When you do speak up, it's very important, and we will miss all of that. Next slide. Dr. Daly, I feel like you've been my partner in crime. Dr. Daly, as you notice, chaired the COVID-19 vaccine work group, which was a little bit of work, and still, still kept us cool. Still was able to see the trees through the forest. And actually, let me rephrase that. He was able to see the forest while still in the middle of the trees, and always had a very insightful comment, and I will miss those conversations. Next slide. Dr. Cotton, you are our immunocompromised hero. And the fact that you can, personalize each of these vaccines for the immunocompromised group is amazing. And you will be sorely missed. I am sure, however, that you will continue to work on the immunocompromised and vaccines issues, and look forward to hearing more about that in the future. That and your smile is very good. All right, next. Dr. Long, I have to say your knowledge of pathogens is incredibly critical for this group. It is very insightful how you understand the immunology and the responses to these pathogens. And even better is you're not afraid to say it. Not that you know the knowledge, but that you're not afraid to speak up and let us understand these mechanisms. So this has been a very thoughtful group who has contributed greatly, have done more than their share of meetings. I did not count them because I was a little worried I'd be depressed and overwhelmed, but you will all be missed and have done an incredible amount of work in a very short period of time and have gone above and beyond the call of duty. So thank you. Wish you all the best. All right. Dr. Chen, would you like to make a few comments? I'm going to do it to everyone, not just you, I promise.
All right. Well, it's been a great privilege to serve over the past 4 years. Certainly, the pandemic was not on my mind when I joined, but I was certainly pleased to serve in whatever capacity we were asked to do. I was also pleased to fill in gaps for kind of special expertise for international vaccines, global health. I continue to be an advocate for this outside of ACIP as well. Diarrheal diseases, that's what I do. You know, that was my conflict of interest statement for many of the meetings. So, you know, I bid you all well. I think that the ACIP is continuing to do great things. We've got a lot of vaccines that are coming down the pike, adult vaccines. So I think that these are the most powerful measures to improve health across the world. And I'm just so pleased to call all of you my friends. So thank you.
Thank you, Dr. Daly.
All right, yeah, thanks so much. So three brief things to mention. First is thank my classmates. That'll be Dr. Chen, Dr. Cotton, Dr. Long. I developed this tremendous respect and affection for you before I ever met you, because we had 18 months where we didn't meet in person. So just appreciate that so much. Thank you so much. And then a second is a thanks to the CDC personnel that I got to work with. These comments are directed at the work group leads who I worked with, but also with the other individuals who kind of staffed those work groups. I was so struck by the honesty, the integrity, the work ethic, but then also just, these are outstanding scientists, and they sacrifice a lot, and I think we as a country lose sight of that. And maybe it's because it's behind closed doors and we don't know that, but I got to sort of be in the room seeing these people do this tremendous work. And so I just have so much respect and admiration for the folks at the CDC who I got to work with. And those qualities serve us well as a nation, that those are the people who are doing the nation's public health. And then third, for myself, I'm going to borrow a quote from John le Carré. His great character, George Smiley, you know, when he was reflecting on decades of work with the British Secret Service, said simply, I'm grateful that I had the opportunity to serve. Thanks.
I love how you compare us to the Secret Service. All right, Dr. Cotton.
No, just service, just service.
Just service, Dr. Cotton.
Thanks very much. It has been an absolute honor to serve. I am so thrilled to have been able to move some projects forward, and I appreciate all the collaboration and input. I would like to very much thank my classmates who've been wonderful. I hope that we all maintain our friendships. It's been a pretty intense time, especially those COVID meetings. And so that part's been really wonderful. I have been so amazed by the colleagues at the CDC, the amazing high quality work. I have never seen a work of such intensity, depth, and just sheer commitment. I would like to thank specifically the work group leads for the groups that I chaired, which Tara Anderson was amazing. We worked fully virtually and got that Shingrix recommendation for immunocompromised host, for which yesterday I spoke about how much of a change that's been. And then for RSV, Michael Melgar and Amadea Britton have just been absolutely spectacular, and I know that leadership has been fully engaged. I'd also like to thank Melinda and then Dimitri Daskalakis. I'm really excited for the future. I've been told that my colleagues here promised to continue to wave the immunocompromised host flag for that 7% of Americans, and let's make sure that they maintain good representation. And then I'm looking forward to doing more research on that topic in the future, so hopefully collaborate with many of you. Thank you very much.
Thank you. Dr. Long.
Nothing especially novel, but want to take the time to celebrate some of the things. The first is the remarkable resources that we have in this country that are brought to bear to take care of our people. So the CDC, who doesn't always get the best high line on the news, is a remarkable resource, having worked in many others. The people at CDC have such high ability, high purpose, and they are unrecognized heroes. They bring to the work groups critical data, carefully laid out, ask us what more we need to do, and try to find that. So I can't say enough about that. And then my colleagues around the room, I know what each of your favorite drink is. I won't mention Matt Daly's, the height of his beer stein. I wasn't going to mention that, but I forgot. But your expertise, your thoughtfulness, your respectful way in which you say it, and always putting the people in front of us in the very top of the list. So thank you very much. I have appreciated the time here.
I mentioned how much service y'all did, and I don't think anyone can understand this. Usually, as a voting ACIP member, you do 12 meetings in your 4 years. So 3 a year, and they're usually just 2 days. To give you some idea of what this class has given, in 2021, they did 17 meetings. In 2022, 11. 2023, 7. And as of today, 2024 will be 2 meetings. Y'all have done 37 meetings. You signed up for 12. You signed up for a couple hours of work groups and have gone far and beyond. This has been almost an unpaid full-time job for the 4 of you, and there's no way to thank you for your service. So thank you. And are y'all ready to tackle some more? Oh yeah, more applause. More applause. And I want to hear everyone's favorite drink later, Dr. Long. Okay, let's move on to meningococcal vaccines and tackle some more vaccines before y'all leave. Dr. Lair, would you like to start this session?
Good morning. We're to the meningococcal vaccine session. Next slide. I'd like to thank the work group members, myself and Dr. Chen will be sorely missed. I'd also like to thank the CDC contributors, the work group liaisons, and as always, I'd like to thank Dr. Sheely for her hard work corralling the meningitis work group into coming to some good conclusions. Next slide. We have 2 terms of reference. We're focusing right now on GSK's MenABCWY vaccine, and we hope to come to a vote in the next year. And with request from members of the work group, we are actually revisiting the adolescent meningococcal vaccine schedule, and also hope that will come to a vote in the next year. Next slide. Today's agenda, there'll be an epidemiology update from Ms. Amy Rubis. We'll be having a presentation from GSK on their pentavalent vaccine from Dr. Son. And then Dr. Shealy will give work group considerations regarding the men ABCWY vaccine and the discussion of potential risk groups for men B vaccination. Next slide. These are the policy questions that we're asking ourselves. They're similar to the pentavalent vaccine that we approved recently. And so specifically, should the pentavalent be included as an option for men ACWY and men B vaccination in people currently recommended to receive both vaccines at the same time? And so that would be, for example, 16-year-olds. And then a second question is, should this vaccine be included as an option for people who are currently recommended to receive men ACWY only, for example, 11 to 12-year-olds? And then the final question, should the pentavalent vaccine be included as an option for people currently recommended to receive men B only during a serogroup B outbreak, as an example? When we had these questions in the past, the work group decided that we would just go with option 1 here, but all 3 policy questions are on the table for this vaccine. Next slide, please. Upcoming ACIP meetings in October, we hope to present the grade and evidence to recommendations framework and cost effectiveness analysis for the pentavalent vaccine, and we hope to have votes on these topics in February. And next, I think we'll move on to Ms. Amy Rubis for the epidemiology of meningococcal disease in the United States. Thank you very much.
Thank you. Good morning. Next slide. Today, I will describe the current epidemiology of meningococcal disease and review recent notable cases and outbreaks. Next slide. Meningococcal disease cases are reported to CDC through the National Notifiable Diseases Surveillance System, or NNDSS. And additional serogroup and outcome information, along with other clinical characteristics, are collected from all jurisdictions through Enhanced Meningococcal Disease Surveillance, or EMDS. All available isolates are also submitted to CDC for whole genome sequencing as part of EMDS. Next slide. Meningococcal disease surveillance data are typically finalized in the fall of the following year. For 2023, overall case counts are not complete, and serogroup is still missing for 14% of cases. Clinical characteristics for 2023 cases are also not complete yet. Additionally, we have not yet received and tested all available isolates for 2023 to confirm serogroup, sequence type, and antimicrobial susceptibility. Next slide. As background, meningococcal disease incidence in the US has declined dramatically between 1996 and 2019, with further declines in 2020 and 2021. However, in 2022 and 2023, we've been seeing a rebound. Based on preliminary data for 2023, we had 423 cases, which equates to the highest incidence we've seen since 2014. Next slide. This figure shows the incidence by serogroup over time, and you can see that on the next slide. In 2023, the serogroup that is increasing very sharply in incidence is serogroup Y. Next slide. So first, I'll discuss the main strain that's contributing to this increase, serogroup Y, sequence type 1466. Next slide. In many jurisdictions, we're seeing increases in serogroup Y that are primarily due to sequence type 1466. This strain is susceptible to all treatment and prophylaxis antibiotics. The number of cases caused by this strain increased from 31 in 2022 to 122 cases so far in 2023. And our 2023 numbers are still preliminary. Next slide. We don't have complete epi data yet on all of these cases, but of those we have data for, we are seeing a predominance of cases, 64%, among Black or African American persons, and there are also a disproportionate number in people with HIV. A majority of these cases had a clinical presentation other than meningitis, with 62% of cases presenting with bacteremia. 4 cases were in individuals who previously received MenACWY vaccine. All 4 were people with HIV. 3 were vaccinated more than 7 years prior to onset, and 1 received a single dose 3 years before onset, so none of these individuals were up to date with MenACWY vaccine per ACIP recommendations. Next slide. We're also seeing a really unusual age distribution among the cases caused by this strain, with almost no cases in children or adolescents. Next slide. For comparison, the age distribution of serogroup Y cases from 2015 to 2019 is added here in dark green. Serogroup Y cases historically have been mostly in older adults, 65 years of age and older, but with some cases in children and adolescents. Next slide. Cases have been detected across the US, but do seem to be more concentrated on the East Coast. Next slide. A HAN health advisory was released summarizing this increase on March 28th, highlighting the need for providers to have a heightened suspicion for meningococcal disease, particularly among Black or African American individuals and people ages 30 to 60 years, and encouraging public health and providers to ensure people are up to date with MenACWY vaccine, including people with HIV. Several jurisdictions have also released their own HAN advisories about increases in serogroup Y. Next slide. Our 2024 data is obviously very preliminary, and we don't have complete serogroup or demographic data yet for cases reported so far, but I do want to highlight that as of June 11th, 251 cases have been reported to CDC for 2024 so far, compared to 164 cases as of this date in 2023. Serogroup is still missing for 28% of 2024 cases, but of those with known serogroup, 103 or 57% are serogroup Y. Next slide. So now moving back to the overall epidemiology of meningococcal disease. Next slide. This figure shows the incidence by age group and serogroup from 2012 through 2021. Serogroup B is shown in blue. Serogroups A, C, W, and Y are shown collectively in yellow, and cases with other or unknown serogroup are in gray. Incidence and serogroup distribution vary by age group. Next slide. With the highest incidence observed in children less than 2 years of age and adults greater than 85 years of age. Next slide. A peak in incidence is also observed among adolescents and young adults 16 to 20 years of age. Next slide. Serogroup B is the predominant serogroup in children less than 5. Next slide. In children and adolescents 5 to 20, serogroup B accounts for approximately half of cases. Next slide. And in adults greater than 20 years of age, serogroups C, W, and Y cause the majority of disease. Next slide. In 2022 and 2023, we saw a different incidence distribution across age groups. Overall incidence during this time period was lower than the previous slide. Next slide. But we saw a peak in disease in 26 to 64-year-olds, driven by the ST1466 serogroup Y cases described earlier. Next slide. This figure shows incidence of meningococcal disease by race from 2015 to 2023. Next slide. And you can see that in 2022 and 2023, we've seen an increase in incidence among Black or African American persons, consistent with the demographic characteristics of the ST1466 cases driving the increase in incidence in those years. Next slide. We looked specifically at incidence by race among 11 to 20-year-olds to see if there are any disparities among adolescents that may be impacted by changes to the adolescent schedule. Case counts are too small to look by year, but we can see that the average annual incidence across 2015 to 2023 is highest among Black or African American persons. Next slide. This figure shows incidence of meningococcal disease by ethnicity from 2015 to 2023 for all ages. Incidence among Hispanic individuals is higher starting in 2019. Next slide. Again, when we look specifically at incidence by ethnicity among adolescents, case counts are too small to look by year, but we can see that the average annual incidence from 2015 to 2023 is higher among cases in 11 to 20-year-olds that are not Hispanic or Latino. Next slide. In addition to the ST1466 serogroup Y cases, we are also continuing to see penicillin-resistant and/or ciprofloxacin-resistant cases, and I'll provide an update on those now. Next slide. We're seeing both penicillin-resistant and ciprofloxacin and penicillin-resistant cases that are mostly serogroup Y. This strain is not related to the ST1466 cases just described, and instead is mainly sequence type 3587 with some isolates in closely related sequence types. This strain is disproportionately affecting Hispanic individuals. We're also seeing ciprofloxacin-resistant only cases, and these are mostly sporadic cases and are not related to the ST3587 strain. Next slide. You can see that in 2023 and 2024, we've seen a big increase in penicillin-resistant cases, shown here in red, and ciprofloxacin and penicillin-resistant or dual-resistant cases, shown here in purple. We've received 24 isolates of the dual-resistant strain to date for 2023, and 19 so far in 2024. And this is compared to 5 to 8 per year over the last few years. The numbers for 2023 and 2024 are not final and may increase. We're also seeing a number of ciprofloxacin-resistant only cases each year, shown here in blue, with an increase in these cases this year. Next slide. And here we've mapped where the cases since 2018 have been reported. Again, with the penicillin-resistant only cases in shades of red, dual-resistant cases in shades of purple, and ciprofloxacin-resistant only cases in shades of blue. In each case, darker shades reflect a greater number of reported cases. You can see that they're sort of scattered across the country, but next slide, with some geographic clusters in particular metro areas. Next slide. Looking more closely at the resistant cases, case patients across all strains have similar median ages, though slightly higher among penicillin-resistant only cases, and luckily have had a pretty low fatality rate. Next slide. However, one notable feature is that the majority of cases have been reported in Hispanic individuals for both the dual-resistant cases and the penicillin-resistant only cases. This is not the case among our ciprofloxacin-resistant only cases. Next slide. In terms of serogroup, next slide. Most of the dual-resistant and penicillin-resistant cases are serogroup Y or have a serogroup Y backbone and appear genetically related. Next slide. However, among the ciprofloxacin-resistant only cases, the majority were serogroup B or non-groupable, but there were also serogroup C, W, and Y cases. Next slide. In addition, we've been trying to collect travel history from the people with cases caused by these strains. Only a minority of cases have reported travel history. Next slide. But of those, several patients with the dual-resistant or penicillin-resistant isolates have travel history to Central America or the Caribbean. Next slide. We've also had one additional dual-resistant case reported in an El Salvador resident, and 2 penicillin-resistant only cases reported in Mexico residents who were in the US at time of onset. Next slide. Guidance is now available on the web and was recently published in MMWR, updating our prophylaxis strategy to avoid use of ciprofloxacin for prophylaxis of close contacts of patients with meningococcal disease in areas with ciprofloxacin-resistant cases. Next slide. This guidance has been implemented in several jurisdictions, as shown here, with the earliest implementation in the darkest blue and lighter blue reflecting more recent changes in guidance. Next slide. We've also continued to see meningococcal disease outbreaks in recent years. Next slide. This table shows a summary of meningococcal disease outbreaks from 2022 to present. 9 outbreaks have occurred in this time period, including a large serogroup C MSM outbreak, a small serogroup C outbreak among people experiencing homelessness, a small serogroup B outbreak in college and surrounding community, a large statewide serogroup Y ST1466 outbreak, a serogroup W community outbreak, an outbreak of serogroup B in an Amish community, another outbreak among people experiencing homelessness, this one serogroup Y, an outbreak in a correctional facility, and an outbreak associated with travel to the Kingdom of Saudi Arabia. I'll now provide more details on some of the recent or ongoing outbreaks. Next slide. In Virginia, there's an ongoing statewide outbreak of ST1466 serogroup Y, with 36 cases reported since June of 2022. 7 deaths have been reported for a case fatality rate of 19%. The average case fatality rate for serogroup Y cases for the past 5 years was 12%. 28 of the 36 cases were in Black or African American persons, and the age range is 16 to 82 years, with 64% of the cases falling in the 30 to 60 age range. No connections have been identified among any of the cases to date. Next slide. At the end of 2023, there was a serogroup B outbreak in an Amish community with 6 confirmed cases and 5 additional suspected cases. All of the cases were in children ranging from 1 to 10 years of age. Next slide. Mass prophylaxis was recommended for the approximately 170-person community. 83% coverage was achieved, but not all at once. There was 1 additional case approximately 1 month after prophylaxis. Next slide. Vaccination with 2 doses of Bexsero was recommended for all people in the community aged 8 weeks and older. This was the first time MenB vaccine has been recommended for people less than 10 years of age in the US, but this recommendation was based on extensive safety data in infants in the UK and elsewhere. 94% coverage was achieved with the first dose of Bexsero, and 56% coverage was achieved with the second dose. All second dose recipients were less than 18 years of age. Next slide. There's also an ongoing serogroup Y outbreak among people experiencing homelessness in Colorado. This outbreak is caused by a penicillin-resistant ST3587 strain. This strain is resistant to penicillin only and not ciprofloxacin. This is the first time this resistant strain has caused an outbreak in the US, and this is a different population from the one primarily affected by the strain. Next slide. Finally, the outbreak associated with travel to the Kingdom of Saudi Arabia. As of June 13, 2024, 14 total cases have been reported in 4 countries, 6 in the US, 4 in France, 3 in the UK, and 1 in Norway. 10 of the cases were in adults with travel history to KSA, while 4 were in children who were close contacts of travelers. 12 cases have been serogroup W, 1 serogroup C, and 1 is non-groupable. All of the travelers participated in Umrah, and none of the travelers are known to be vaccinated, although vaccination history is unknown for several. Isolates from 4 cases were found to be resistant to ciprofloxacin. Next slide. A HAN Health Advisory and MMWR notes from the field were released summarizing this outbreak. Based on the isolates resistant to ciprofloxacin, a recommendation was made to discontinue ciprofloxacin use for prophylaxis of close contacts of patients with travel to KSA. Next slide. In summary, incidence of meningococcal disease increased in 2023 to above pre-pandemic levels, and this increase was primarily driven by serogroup Y ST1466 cases. The increasing burden of disease driven by ST1466 is being observed primarily among those aged 30 to 60 years. We don't know if that's just the epidemiology of this strain or if the adolescent vaccination program is successfully protecting the 11 to 20-something age group. Ciprofloxacin resistance is increasing both domestically and in imported cases, and multiple jurisdictions have moved away from using ciprofloxacin for prophylaxis. A growing number of the isolates resistant to ciprofloxacin are serogroups other than Y. Next slide. ST1466 is predominantly affecting Black or African American persons, and this is leading to an increasing disparity in incidence among Black persons compared to other racial groups. And finally, there have been a large number of outbreaks since 2022, and in many cases, these outbreaks are affecting minorities or disadvantaged populations. Next slide. Thank you.
Dr. Long.
That was just wonderful. You know, meninge is always interesting and has new tricks all the time. I tried to figure out, given if we have a case of meningococcal disease, we need to give prophylaxis very quickly. I think I figured out, although I don't think you ever quite said, given a case in the United States right now, the percentage of ciprofloxacin resistance would be somewhere between 10 and 20%. Did I figure that out correctly?
No, it's not quite that high overall in the United States, and it really varies by jurisdiction. There are several jurisdictions that have had no ciprofloxacin-resistant cases, but in some of the areas that have already changed the guidance, they have more than 20% of their cases that are resistant to ciprofloxacin. So, you know, in a jurisdiction that hasn't had any ciprofloxacin-resistant cases, we would recommend that they continue to use ciprofloxacin for prophylaxis, though the other antibiotics are routinely recommended and could also be used. But in those jurisdictions that have seen a higher proportion of their cases resistant, they've made a recommendation in particular metro areas, or in some cases, permissive recommendations statewide to not use ciprofloxacin for prophylaxis.
And it doesn't seem to follow the serogroup. The resistance is not all in one serogroup, although I understand some outbreaks are, and that could affect it.
It's still mostly serogroup Y, but we are seeing resistance in all of the other serogroups.
Dr. Cotton.
Thank you very much for an excellent presentation. We have taken care of some of these cases at my hospital, so it's been dramatic illness with deaths seen. I'm wondering if you could comment on prophylaxis in the setting of eculizumab and other terminal complement pathway inhibitors. We have an increasing number of patients on those agents for which obviously there's a much higher rate of meningococcal disease, and I really struggle with what the best choice of antimicrobial prophylaxis is. And before you answer that question, in the future, if the CDC could include guidelines on optimal duration for antibiotic prophylaxis in the setting of terminal complement pathway inhibitors, for which I don't think there's any great answer, that would be helpful, because otherwise I get those questions. Thank you.
This is Dr. McNamara. I can take that question. So although we are seeing a relatively large proportion of our overall invasive meningococcal disease cases in the United States being resistant to penicillin, it's important to remember that the strains that cause disease in people who are taking eculizumab or otherwise have complement deficiency are really systematically different from the overall strains that cause disease in the United States, because they're susceptible to strains that are typically not invasive in anyone else. And so the proportion, you know, what we would really need to understand is kind of the proportion of carried, asymptomatically carried meningococci in the United States that are resistant to penicillin. You know, as Amy presented, the main strain right now that is penicillin resistant is that serogroup Y strain, and we are seeing some non-groupable isolates that are resistant to penicillin, but not nearly as many. And so because people taking eculizumab and, you know, with complement deficiencies are very frequently getting disease from these sort of, you know, non-groupable strains that are typically asymptomatically carried, I would expect that a much lower proportion of the cases among those patients would be caused by penicillin-resistant strains than what we're seeing in the U.S. overall. That said, I do think this is an important concern, and as we continue to see penicillin resistance increasing and seeing it in additional serogroups, I do think this is something important for us to look into. Thanks.
Thank you very much. And any further comments on duration of antimicrobial prophylaxis after eculizumab?
I mean, we don't have any, as you said, right, we don't have any current CDC guidance on that. When patients are taking eculizumab, the risk is constant. There's not a point at which the risk would decrease. So I guess that's all I can say.
And many of them are on immunosuppression, and so they are likely to have a markedly attenuated vaccine response. So, okay.
Dr. Schechter.
Good morning, and thank you for the presentations. Two questions. For the Virginia outbreak or some of the other outbreaks, I'm wondering if tobacco use or smoking exposure was a risk factor given a population that wouldn't routinely be recommended for vaccine, are there any other interventions that, any other public health messages around that? And question 2 is around what is known about, given the age groups mentioned, the effect of routine preteen vaccination on colonization compared to UK or other information on early childhood or routine childhood vaccination.
Thank you. So for the first question about the Virginia outbreak and smoking, there were kind of a handful of cases in that outbreak that were tobacco smokers. One of the real challenges with that outbreak has been that there have been, a few tobacco smokers, a few people with a history of drug use, a few cases among people with HIV, but not kind of one risk factor that tied everything together, and no connections among the cases. So they haven't been able to kind of define a population to target for vaccination or some other intervention. And for your second question about the effect of the vaccine on carriage, I'll defer to Dr. McNamara.
Sure, thank you. So there are some data suggesting that some meningococcal conjugate vaccines do have an impact on asymptomatic carriage of the serogroups included in the vaccine. There's very strong data for serogroup A monovalent vaccines that those do reduce carriage. Also quite good data on serogroup C monovalent vaccines. The data on the quadrivalent meningococcal vaccines is more limited. There was a recent study in the UK that did look like it might show an impact as well of the quadrivalent conjugate vaccines on asymptomatic carriage. But I don't think we have a really clear sense in the United States of whether we've successfully obtained herd immunity and reductions in carriage in older age groups, despite the preteen vaccination program that we have. And it's also possible this may vary between the different conjugate vaccines, with the ones initially implemented in the United States being different from the ones in the UK, and more recently we've had changes in which conjugate vaccines are primarily being used in the United States, and that could also change the impacts potentially in the future.
Dr. Cotton, did you have another question? Dr. Long.
Yes, Dr. Schechter, you're a man after my own thinking. I've thought if we look at the epidemiologic era of meningococcal disease, and that cases began to fall long before vaccine. It doesn't fit the few number of cases that we have that the vaccine has been the cause of that. We don't have evidence that young children are the reservoir. Probably they are the young adults. And the CDC published a paper that I really paid attention to about 40 years ago about bar patronage. And the epidemiology of the slope better reflects our taking smoking out of common places. And I do wonder, and the military with the increase went along with that. And the other thing is that alcohol makes your cilia get a little bit distracted, and they don't beat as with such direction. They get a little wobbly. So those things are maybe thought, both the irritation of the smoke in the environment and the decreased ciliary function, that may be part of the epidemiology. With the cases so low, but so dramatic, one wonders about the vaccine program. I'm sure we're going to hear more about that. But I think that we should pay attention to who is left as a smoker in the United States and the places where they smoke. And if that is a risk factor, this very unusual disease.
Any other questions, comments? I don't see any of our liaisons with raised hands either. All right, so we will move on to the GSK Pentavalent Vaccine Immunogenicity and Safety presented by Dr. Wendy, I want to say Son, is that correct? Please correct me if it's Son and not Son.
That is correct. It's Son. Thank you very much. Could you share, could you allow us to share our video and our voice? And our slides as well?
They are working to pull that up. Thank you.
Thank you.
Okay.
Please do let us know when you can see our slides.
Yes, sounds perfect and slides are presented.
Thank you. Thank you. I will start my presentation, and good morning. My name is Wendy Sohn, and I am the Global Medical Lead for GSK Neisseria vaccines. And today I have the privilege of presenting on behalf of a large team at GSK, as well as many study investigators and the thousands of study participants and their parents worldwide who have contributed to generating the clinical data on our MenABCWY vaccine. It's important to note that IMD is a single clinical entity, and the diagnosis and treatment are not based on the serogroup. And therefore, a concerted effort to prevent IMD in adolescents and young adults is needed. Over the past 9 years, serogroup B has been responsible for most IMD cases in individuals 16 to 23 years of age. And despite this, less than 12% of adolescents have completed MenB vaccination, and moreover, vaccination rates were even lower among those with high-risk medical conditions. A pentavalent vaccine could help address the disease as a whole by providing protection against the 5 most common serogroups in one vaccine. GSK designed a MenABCWY vaccine combining 2 vaccines licensed in the US, Menveo and Bexsero. The antigenic components are equivalent to those in the original vaccine, with the MenACWY component provided as a lyophilized vial and the MenB as prefilled syringe. Clinical and real-world evidence demonstrates the safety, immunogenicity, and effectiveness of these 2 licensed vaccines in both healthy participants and in the high-risk groups. The proposed indication for our MenABCWY, which I will refer to as Penta, is for active immunization to prevent IMD caused by serogroups ABCWY in individuals 10 to 25 years of age as 2 doses at least 6 months apart. Penta is supported by a comprehensive clinical development program, including 12 completed studies with more than 7,000 participants from 13 countries. An ongoing phase 2 study assesses the longer interval of 2 to 4 years between the first and second dose. US participants represented approximately 1/3 of the total number of participants, as well as those exposed to the pentavalent vaccine. 2 phase 3 studies were conducted to assess the safety and immunogenicity of Penta compared to Bexsero and Menveo in both MenACWY naive and prime participants. Study 72, the pivotal phase 3 study, assessed the safety and immunogenicity of 2 doses of Penta given at 0.6 months compared to Bexsero and Menveo in approximately 3,600 participants aged 10 to 25 years. Almost all participants in this study were MenACWY naive. Participants received either 2 doses of Penta, represented in orange, 2 or 3 doses of Bexsero in blue, or 1 dose of Menveo in green. From here on, these colors will represent the respective vaccines. Due to time constraints, we are presenting here only the data for the 2-dose Bexsero schedules and the comparison with Penta. A second phase 3 study, study 19, assessed the safety and immunogenicity of 1 and 2 doses of Penta compared to Menveo in participants who had previously received a MenACWY vaccine at least 4 years prior. This study included 1,200 participants aged 15 to 25 years. Both studies were conducted in healthy participants with no underlying medical conditions. Study demographics of these 2 studies were well balanced and represented the racial and ethnic diversity of the countries where participants were recruited. Notably, US participants matched the racial and ethnic distribution of the general US population. Now let's turn our attention to the results, starting with the safety data. Solicited local and systemic adverse events were recorded after each dose of penta and Bexarel and a single dose of Menvio. The most common local adverse event was injection site pain, and the most common systemic adverse event was fatigue. Most of the solicited adverse events were mild or moderate, with an average duration between 1 to 4 days. Rates of adverse events did not increase with subsequent doses. Overall, the reactogenicity of penta was similar to that of Bexarel and higher than Menvio. Similar results were seen in the second phase 3 study, the study 19. The integrated safety summary includes data from all 12 studies regarding unsolicited adverse events in participants that received at least one vaccine dose. The rates of unsolicited adverse events were similar with Bexarel, but higher than after Menvio. The rates of serious adverse events, related AEs, and medically attended AEs were also comparable for penta and Bexarel. The top category of related unsolicited events was general disorders such as fatigue and injection site pain, followed by nervous system disorders such as headache and dizziness. There were 4 deaths among the approximately 7,000 participants, all of which were considered unrelated to vaccinations. 2 were suicides, 1 was a drug overdose, and 1 was due to poisoning. In summary, this extensive safety database demonstrates that penta was well tolerated and has a favorable safety profile comparable to Bexarel. Next, moving on to the immune response for serogroups ACWY and for serogroup B. Due to the uncommon nature of IMD, it is not feasible to assess efficacy through clinical trials. Over the past 20 years, the licensure of these vaccines have relied on HSPA. ACWY vaccines are polysaccharide conjugate vaccines with capsular polysaccharide antigens that are highly abundant and conserved across all strains in the serogroup. Demonstration of bactericidal activity against one reference strain infers protection against all strains in the serogroup. These graphs show the immune response of penta compared to Menvio in the ACWY naive participants. The left graph displays the fourfold rise in HSPA titers of 2 doses of penta compared to 1 dose of Menvio. The immune response was overall higher in those who received 2 doses of penta compared to 1 dose of Menvio, and non-inferiority was demonstrated for all 4 serogroups. The right graph shows 1 dose of penta versus 1 dose of Menvio. The sero response was similar, with slightly lower response for Men-A and higher for CWY, though not statistically significant. This analysis was not powered for non-inferiority. In the prime participants on the bottom row, both 2 and 1 dose of penta were non-inferior to 1 dose of Menvio. These data support that a dose of penta can be used to boost the ACWY immune response in those previously vaccinated with a ACWY vaccine. Next, let us move on to the serogroup B immune response. These graphs show the immune response of penta compared to Menvio in ACWY naive participants. The left graph displays the fourfold rise in HSPA titers Apologies. If we can go back to this slide, yes. The ACWY vaccines are polysaccharide conjugate vaccines with MenB vaccines are subcapsular protein vaccines, and the expression of these vaccines are highly variable across strains. And therefore, an immune response to a specific reference strain does not infer protection against diverse circulating MenB strains. The FDA requested confirmation of the effectiveness of our MenB vaccine against diverse serogroup B strains. And in order to characterize the immune response against a large number of strains, we developed the endogenous complement HSBA and tested against a panel of 110 serogroup B strains that represent 95% of the circulating strains in the United States. These assays can be used to test how well the vaccine performs against many disease-causing strains, and because of this, these data can be used to infer vaccine effectiveness in a real-world use setting. We term this measure immunological vaccine effectiveness, or IVE. IVE was measured through two assessments, the test-based and the responder-based effectiveness. The test-based effectiveness is calculated based on the reduction in the relative risk, with the relative risk defined as the percentage of tests lacking bactericidal activity in the vaccinated group versus the control. The test-based indicates the breadth of immune response against serogroup B, panel of serogroup B strains at a population level. The responder-based effectiveness measures the proportion of vaccinated individuals whose sera killed at least 70% of the strains that were tested. This measure reflects the percentage of participants that achieve broad protection against serogroup B strains. We assessed the immunological vaccine effectiveness for participants that received 2 doses of Penta 6 months apart and 2 doses of Bexsero 2 or 6 months apart. These results show similar immunological vaccine effectiveness across Penta and Bexsero groups, and all 3 groups met the predefined success criteria for IVE with a lower limit of the 97.5% confidence interval well above 65%. For Penta, the test-based IVE was 78%, and 84% of participants were considered responders. Therefore, Penta achieved breadth of bactericidal effect similar to Bexsero administered 2 or 6 months apart. The primary endpoint for non-inferiority of Penta versus Bexsero was based on the endogenous complement HSBA approach. The statistical plan assessed the Bexsero schedules in a hierarchical manner, Bexsero 026, followed by 06 and 02. The shortest dosing interval, the 02 months, met the predefined success criteria and was chosen as the comparator for non-inferiority assessments. The percentage of samples without bactericidal activity was almost identical for Penta compared to Bexsero 02 months, and the success criterion for non-inferiority was met. The non-inferiority of Penta compared to Bexsero 06 months would also have been demonstrated, although this was not a predefined comparison. Overall, the Pentavalent vaccine 2-dose regimen demonstrated breadth of coverage against a diverse panel of serogroup B strains and showed non-inferiority compared to Bexsero. We also assessed non-inferiority using the traditional HSBA assay. The fold-fold rise in HSBA titers were lower for Penta compared to Bexsero for 1 or more reference strains, and the secondary endpoint for non-inferiority was not met. We consider that the lower immune response against specific reference strains may not be clinically relevant, given that the primary endpoint, the immunological vaccine effectiveness of Penta, was comparable to Bexsero. IVE assessed by the endogenous complement HSBA against the 110 strain panel takes into account the synergistic effect of antibodies against multiple vaccine antigens and could best reflect the performance of a multi-component MenB vaccine in the real world against diverse circulating strains. Lastly, the immune persistence and booster up to 24 months. A phase 2 extension study assessed the persistence and booster response of Penta and Bexsero. Let's focus on the top left graph for FHBP. Here we see the percentage above the lower limit of quantification at baseline after 2 doses of Penta or Bexsero at 24 months and at 5 days after a booster dose. 2 years after the Penta or Bexsero series, the percentage above LLOQ declined, but continued to remain higher than baseline. A single dose of Penta or Bexsero elicited a rapid and robust immune response within 5 days, higher than after the initial 2 doses, demonstrating immune memory up to 24 months after vaccination. A similar pattern was seen for the other 3 reference strains. In summary, the Pentavalent vaccine combines the licensed MenB and MenACWY vaccines, each with their own well-established clinical profiles and supported by clinical and real-world data. In addition, the Penta clinical development program demonstrated safety and immunogenicity in adolescents and young adults. Penta was tested against a broad panel of 110 serogroup B strains, representing 95% of the serogroup B US disease-causing strains. The persistence of the immune response was demonstrated up to 24 months. In view of the current reassessment of the meningococcal vaccination program, these data support the use of our pentavalent vaccine to meet the current and evolving US epidemiology. Penta can offer the opportunity to improve vaccination coverage in all adolescents and young adults. And most importantly, the pentavalent vaccine represents the evolution of IMD prevention as one vaccine preventable disease. One disease, one vaccine. Thank you for your valuable time, and I'll stop here for any potential questions.
Once again, we'll start with questions from the voting members and then the liaisons. Any questions from the voting members? Yes, Dr. Long.
Sorry. It's your last statement about persistence of antibody at 24 months. So if I just want to be sure I understand this. It probably is the slide just before the 2 summary slides. So if we look at, so the first response is after 2 doses 6 months apart. The third set of columns is 24 months from the first dose or from the second dose. You'll clarify that. And it looks kind of low for 3 of the 4 strains you're showing us, with sometimes less than 20%, with still having bactericidal titers. So that's a bit of a cause of worry. So that's after 2 doses in 2 years. I appreciate that the booster response at 24 months causes high bactericidal titer, but the question is, that's waning protection by 24 months rather than, for me, than persistence of protection at 24 months.
The antibody titers at 24 months after 2 doses of vaccination range between 28% to higher results for NADE. So the results were different depending on the specific reference strains that we're looking at different antigens. And this has been consistent through our phase 2 trials as well. What is reassuring is that there is a persistent response, and it is still higher than what you see before vaccination. And in another analysis, we did compare with the age-matched naive cohort who had never received a MenABCWY or MenB vaccine. And in those populations, the baseline was lower than what you are seeing at 24 months. And we do now have real-world evidence from studies that have occurred where Bexsero has been used in real-world programs. The most relevant data comes from South Australia, where they implemented a MenB program, a Bexsero program in adolescents. And within 3 years of the program, the incidence in this population for MenB IMD in adolescents decreased by 78.5%, and the vaccine effectiveness was sustained at 89%. So there is now additional data from the real-world evidence that provides more information on the duration of protection than what was anticipated based on the immunogenicity alone that was expected for only 1 to 2 years.
Thank you, Dr. Shaw.
Yeah, thank you for this presentation. I just had a question, just so I understand the endogenous complement SBA assay. So I guess the way it's described, it sounds to me like it's a qualitative assay. Is that correct? Because it's kind of yes, no, that you're responsive over time. So it's not an assay where you can look at, you know, how variations in, you know, geometric mean titers or something like that vary over time. Is that correct? I mean, I understand the value of the assay, but it's kind of a qualitative assay. Is that correct?
That is correct. If we can go to slide number 26, I can provide a little bit more detail on the difference between these two assays. In the traditional assay, the way that it works is that the vaccine's complement is inactivated and the sera is diluted seriofolds and an exogenous complement is added on. The value of this traditional approach is, as you said, that we can measure a quantitative approach of GMTs, GMRs, and pol-4 and titers. But there is also a limitation to this assay that you do need a seronegative complement donor, which is the rate-limiting step, and this inhibits testing using this method against a large number of strains. The endogenous approach does not inactivate the complement, and in this way, the sera is only diluted up to 4-fold because if we dilute further, the concentration of the complement is also diluted. So a test is reported positive if at a 4-fold dilution, 50% of the strains are killed. There are advantages, and as you said, the number one advantage is this allows testing against a large number of strains, which is one of the most critical questions when it comes to MenB vaccines. And the second is that it takes into account the combined synergistic effect of antibodies against multiple vaccine antigens, and this has always been a question for a multi-component vaccine such as Bexsero.
Thank you very much. In the, I keep forgetting the words this morning. Due to time, let's move to the next session, which is going to be done by Dr. Schilly, which will talk about work group considerations.
I'm just waiting for my slides. Good morning. I will review the work group's interpretation of the GSK MenABCWY pentavalent vaccine clinical trials data, followed by a discussion of potential risk groups for MenB vaccination. Slide 2. The work group reviewed safety and immunogenicity data from the clinical trials. The work group noted that the demographics of the clinical trial participants may not be reflective of that of the U.S. population, but rather reflective of the countries in which the trials occurred. Slide 3. The phase 3 studies assessed solicited local and systemic adverse events after each dose of pentavalent, MenACWY, and MenB vaccine. The work group reviewed safety data from both phase 3 studies. An integrated safety analysis of 7,048 participants assessed unsolicited adverse events within 30 days of vaccination, including those related to vaccination, leading to withdrawal, medically attended, and related medically attended. Serious adverse events and deaths during the entire study period were reviewed. Slide 4. This slide depicts the solicited local and systemic adverse events within 7 days of vaccination for trial V7272. The work group reviewed similar data for trial MenABCWY19. Slide 5. This slide depicts unsolicited adverse events within 30 days of vaccination, serious adverse events, and deaths from the integrated safety analysis. Slide 6. Solicited local adverse events occurred with similar frequency among pentavalent recipients and MenB recipients, and less frequently among men ACWY recipients. Solicited systemic adverse events occurred with similar frequency across the 3 vaccines. Unsolicited adverse events generally occurred at a slightly higher frequency among pentavalent recipients compared to MenB recipients, and were generally lowest among men ACWY recipients. An exception is for adverse events leading to withdrawal during the entire study period. Those data were shown to the work group, and adverse events were similar for pentavalent recipients and MenB recipients, and highest for men ACWY recipients. Slide 7. Serious adverse events during the entire study period were similar for pentavalent and MenB recipients, and were less common for men ACWY recipients. The frequency was 2% or lower for each group. The rate of related serious adverse events during the entire study period was similar for pentavalent and MenB recipients, 0.1%, and no related serious adverse events occurred for men ACWY recipients. Among pentavalent recipients, there was a new case of seizures, connective tissue disorder, and neuromyelitis optica, which resolved or partially resolved. There were 4 total deaths, including 1 in the pentavalent group, which was caused by a suicide. All deaths were deemed unrelated to vaccination. Slide 8. Immunogenicity against serogroups A, C, W, and Y was assessed by a 4-fold rise in HSBA titers. Similarly, immunogenicity against serogroup B strains was assessed by a 4-fold rise in HSBA titers. Additionally, GSK developed an endogenous complement HSBA assay to assess protection against diverse disease-causing serogroup B strains. The assay included 110 randomly selected strains representing 95% of U.S. disease-causing B strains. Slide 9. This slide depicts immunogenicity to serogroups A, C, W, and Y in men ACWY naive and primed recipients. Slide 10. 2 doses of pentavalent vaccine were non-inferior to 1 dose of men ACWY vaccine in both ACWY naive and primed recipients. Slide 11. 1 dose of pentavalent vaccine was non-inferior to 1 dose of men ACWY vaccine in primed recipients, shown on the bottom. In an ad hoc analysis among naive recipients, shown on the top, confidence intervals overlapped for all 4 serogroups. Responses were greater for pentavalent recipients compared to men ACWY recipients, except for serogroup A, which is rare in the United States. Slide 11. This slide depicts immunogenicity to serogroup B strains. Slide 12. Slide 13, sorry. When compared to MenB vaccine on a 0-2-month schedule, success criteria for pentavalent vaccine were met for 3 of 4 strains. Slide 14. When compared to MenB vaccine on a 0-6-month schedule, success criteria for pentavalent vaccine were met for 2 of 4 strains. Slide 15. The next 2 slides show response to MenB strains with the endogenous complement HSB assay developed by GSK against a broad panel of serogroup B strains. This slide shows test-based IVE, or immunologic vaccine effectiveness, on the left, and responder-based IVE on the right. Slide 16. This slide shows the proportion of samples with serum bactericidal activity against a panel of MenB strains. Slide 17. Success criteria were met for comparisons to both MenB on a 0-2-month schedule and 0-6-month schedule for test-based and responder-based IVE. The response was slightly higher for MenB versus pentavalent vaccine, and also slightly higher for MenB on a 0-6-month schedule versus MenB on a 0-2-month schedule. Slide 18. This slide depicts response after 24 months and booster response to 4 MenB strains. The work group reviewed similar persistence and booster response data for serogroups A, C, W, and Y. Slide 19. After 24 months following pentavalent vaccination, titers waned substantially for B strains FHBP, NHBA, and POR-A. A robust booster response was elicited. Confidence intervals overlapped with those for MenB on a 0-2-month schedule. Regarding serogroup ACWY data, which were shown to the work group, after 24 months, titers waned substantially for serogroup A. Variable waning was observed for serogroups C, W, and Y. A robust booster response was elicited. Slide 20. In summary, the safety profile of pentavalent vaccine was favorable and similar to that of MenB, and more adverse events occurred for pentavalent compared to Men-ACWY. Regarding immunogenicity, pentavalent was non-inferior to Men-ACWY in most study groups. The comparison of one-dose pentavalent versus one-dose Men-ACWY in naive recipients was not powered for non-inferiority, although results were favorable for all serogroups except A. Pentavalent was non-inferior to MenB based on immunologic vaccine effectiveness. Pentavalent was non-inferior to MenB 0-2 months for 3 strains, FHBP, NADA, and NHBA, and MenB 0-6 months for 2 strains, FHBP and NADA, based on HSBA. After 24 months, titers waned substantially for serogroup A and for B strains FHBP, NHBA, and POR-A. A robust booster response was elicited. Slide 21. The work group was concerned about the drop in protection at 2 years for serogroup B strains. The work group also noted that the POR-A indicator strain is important because POR-A represents the full outer membrane vesicle component of the vaccine, and response to this indicator strain has bearing on cross-protection. Before moving on to the next portion of this presentation, I will now pause for questions.
Dr. Shaw.
Sorry, thanks. Just one quick question. When you're saying strain, you don't mean a bacterial strain, you're meaning a bacterial protein. Is that correct? Because the POR-A and these things are proteins, are not
Yeah, those are antigens, and the strains, the various MenB strains carry those particular antigens,
Okay,
which
they're antigens.
represents coverage provided by the vaccine.
Okay. Okay.
Dr. Daly.
Yeah, a quick question about terminology, where the term immunologic vaccine effectiveness came from, because I'm just worried that it's going to be misinterpreted, because I just think that's disease prevention in an individual. And I understand if we come up with a new assay, and I don't mean to sound grumpy, but I understand if we come up with a new assay, we need to figure out what to call it. But personally, I think that's misleading, or has the potential to be misleading. Thanks.
Thanks. And I don't know if GSK representatives want to speak to that, but they were the ones who described the results of their assay using the responder-based and test-based IVE terminology.
Thank you. The immunological vaccine effectiveness is not traditional vaccine effectiveness in the sense that you are measuring the reduction in disease when a vaccine is used in the real world. Our immunological vaccination is the reduction in relative risk, with the relative risk being the percentage of tests without bactericidal activity in the vaccinated group versus the control. And by doing this measure, we are able to infer the vaccine effectiveness in the setting of a clinical trial using immune data. And that is why we have termed the measure immunological vaccine effectiveness. This was a way that we could measure the effect or the breadth of immune response against diverse circulating strains, which cannot be done by assessing efficacy through a clinical trial, which is not feasible for this disease.
This is Dr. Daly, and I would still argue in the spirit of transparency and clarity to refer to it with different terminology. Thank you.
I truly believe this is immunologic bridging and not vaccine effectiveness. That has a totally different meaning in the world of vaccines. Any other questions, comments? Dr. Schechter?
Thank you. We currently have the 5-year, the 11-year-old, 16-year-old recommendation for the second dose for the second round of ACWY, and the prior information on serogroup B vaccines. Does this data, realizing there were head-to-head comparisons within the trial, but does this data seem comparable to prior vaccines and the other manufacturers' other vaccines and the intervals, the implications for intervals that we have for the current vaccines?
The work group's interpretation is that yes, the immunogenicity data for this vaccine seem comparable to the comparator vaccines.
Dr. Long?
It's interesting and it's important because for meninge, unlike Haemophilus influenza B, for instance, which is memory is so important, for meninge, because it's so rapidly invasive, there were data from England that suggested it really is, you have to have standing antibody for protection rather than the ability to immunologically respond. So meninge is difficult. And it sounds like for this one, it's at least a 3-dose schedule within 24 months and then repeated. So, Rob, remember me, aren't our recommendations for meninge for people who are at increased risk that it be Q3 years after they're primarily immunized, not Q5? Pneumococcus is 5, but yeah. I'm sorry if I'm...
For MinB, it's 1 to 2 years, although in an outbreak setting, there's permissive language to reboost after 6 months if recommended by public health authorities.
That's for B.
And for ACWY, it's every 5 years,
right.
Unless the person is under 7 years of age, then it's slightly different.
Makes it difficult work for the work group to decide what's the optimal age to give this for the different serogroups more prevalent at different ages.
Dr. Cotton?
Just talking about intervals for booster vaccination, those would apply nicely to non-immunocompromised, but I really worry about the complete lack of knowledge of immunocompromised response to vaccine efficacy, et cetera. So I wonder if it should be less than 5 years, and moving forward, it would be interesting to think if we could include additional data on that, although I don't think that's in the purview of the CDC. I guess I would encourage many researchers to do more research so that we could make good guidance. I worry that we're leaving a significant at-risk population perhaps less well protected. Thank you.
Dr. Shelley, would you like to proceed?
Thank you. Can you pull up the next slide, please? I will now discuss potential risk groups for MenB vaccination. Slide 23. Options for revising the adolescent meningococcal vaccine schedule were presented to ACIP in February. This slide depicts the current schedule, shown in green, and 5 policy options under consideration. With the current schedule, MenB vaccine is recommended for adolescents based on shared clinical decision-making. The 5 options depicted here are for MenB to be either routinely administered, options 1, 4, and 5, or administered to those at higher risk, options 2 and 3. Slide 24. Because changing the MenB recommendations to risk-based is under consideration, the work group has considered groups of adolescents at higher risk for MenB based on congregate living settings. The new ACIP recommendations will not include military populations as per the ACIP charter. Slide 25. The work group identified the groups depicted here who may be at increased risk for meningitis based on congregate living settings. Note the heterogeneity of the groups included on this list. Slide 26. The groups in red represent settings of relatively short duration and such that the adolescent would likely not be in the setting for enough time to allow for completion of the MenB vaccine series. Slide 27. Several factors have been previously identified with increased MenB risk among college students. 4-year college students had a 5.2-fold higher risk of serogroup B disease than non-undergraduates aged 18 through 24 years. The risk among 2-year college students was comparable to non-undergraduates. First-year students were at 3.8-fold higher risk than non-first-year students. On-campus residents were at 2.9-fold higher risk than off-campus residents. And lastly, students participating in Greek life were at 9.8-fold higher risk than other students during outbreaks. Slide 28. The work group prefers to include all college students in a risk-based recommendation. This simplifies recommendations, accounts for changing college plans, and may address equity issues. Slide 29. In 2020, there were about 4 million 18-year-olds in the United States. There are about 3 million recent high school completers annually, which includes those who completed a GED or other high school equivalency credential. 62% of recent high school completers enroll in college, either a 2-year college or more commonly a 4-year college. There are also over 35,000 students enrolled in U.S. boarding schools. These tend to be older children and adolescents, many of whom may be likely to attend college. Slide 30. And regarding congregate living and foster care, the public foster care system serves children through 18 or 21 years and represents a continuum of foster care, including in the home of a foster family, a group home, or a residential program. The public foster care system served 570,000 children in 2022, with 369,000 children in care as of September 30th, 2022. Because federal law requires that children in foster care be placed in the least restrictive, most family-like setting, the number of children in congregate foster care is decreasing. Those who are in congregate foster care typically spend 8 months in that setting. Slide 31. The work group prefers to add inclusive language to the list of groups representing higher risk, such that any adolescent who desires protection may receive MenB vaccine. This includes adolescents who are unaware of their future plans, which may inform congregate living risk. Slide 32. The proposed language is depicted here and reads, work group recommends that adolescents 18 to 21 years enroll in college, either a 2-year college or more commonly a 4-year college. The risk among 2-year college students were at 3.8-fold higher risk than non-undergraduates. 62% of recent high school completers enrolled in U.S. boarding schools. Risk groups include adolescents planning to attend college and adolescents in a congregate living setting, e.g., congregate foster care, boarding school, correctional facility, etc., and who are anticipated to remain in this setting long enough to complete the MenB vaccine series. Any adolescent who desires protection may receive MenB vaccine, even if they are unsure of their future plans, which may inform congregate living risk. Note that the examples provided in parentheses are not intended to be exhaustive. I will now take questions.
Dr. Long.
This seems really problematic, not only in implementation, but so ACWY is not clearly more common in college students. It's that it's front-ended to the first 2 years, but if you take what you showed us was B, and B seems to like to go through colleges. But if you take ACWY and you look at the current epidemiology where young Black and African Americans are more involved, the use of a pentavalent seems inappropriate for this kind of a recommendation. So are you talking about changing the proposed recommendation or the current recommendation for freestanding B vaccine?
Yes.
And then how would that be affected when you wanted to apply the pentavalent? Because that wouldn't work too well.
Could you go to slide 23, please? So rows 1 through 5 represent the proposed options under consideration. And you can see that they allow for harmonization of that second dose of ACWY and that first dose of B as the ages overlap. You'll notice that the B interval here is prolonged compared to the current recommendation. So that second B dose would be timed to more closely coincide just prior to college entrance.
I'm getting a pneumococcal vaccine headache.
Dr. Lair.
So if I were to summarize what the work group is thinking, there has been pushback against shared clinical decision-making for many years. And if we're not going to have shared clinical decision-making for MenB anymore, we need to come up with risk-based guidelines. So that's what the work group is working on and presenting to the ACIP at this point to see, are you comfortable with these risk-based guidelines that we're coming up with? So I think that's where we're coming from. Does that answer your question, Dr. Long? And this is MenB specifically.
Dr. Maldonado.
So I apologize, I haven't kept up in the last couple of years on the combination issue, but working with AAP, this has been highly difficult for us to really resolve, but has this come, so it seems to me that this may be the time to consider, and you may have already done this, just moving everything up to 16 and just saying 16, 2 doses, they get to go to college with that boost right before they get in, and then you avoid shared clinical decision-making, and you're hitting the epidemiologic peak of all the serotypes, unless you decide to go back to infants, which we're not even going to talk about today. So it seems to me that could actually solve this problem that we've been stewing about for many years. It's been a source of headache for all of us. I mean, I'm sure practitioners for sure. And I don't know if that's I'm sure it's come up before, but is this the time to bring it up?
And I mean, the downside of completing the MenB series at 16 years of age is if protection wanes 18 to 24 months after series completion, when they're starting college, so the period of highest risk, right, protection might have waned.
But then you protect them from 16 to 18, then you boost them when they go to college, right when they're walking in the door. Otherwise, you're leaving them vulnerable for a much longer period if you go 11 to 12, and that's always been, you know, we leave our pediatricians in the dust when we don't know what to say about that big period of risk. I mean, yeah, just
And
thought.
Dr. Maldonado, that was the right time to bring that up, so thank you. Dr. Schechter.
Thank you. Following up on that question, is there evidence for partial protection after first dose during that bridging interval? And secondly, is there any thought that with the success of vaccination reducing disease between 11 and 16 years, that if we were to remove the preteen dose at 11 to 12, that over time there might be increased colonization in that group again? Would it recur? Is that a theoretical risk?
So, regarding the 11 to 12-year-old dose, there is, some concern that removing that dose would, not provide enough protection. And I didn't actually hear your first question. I'm sorry.
Oh, if there was a period of a few years where between dose 1 and dose 2, any expectation for partial protection from the first dose? So, certainly longer intervals are associated typically with more increased protection. So for the ACWY doses, a 5-year interval is what seems appropriate. For B doses, I think there are data that are forthcoming on the longer interval between doses, but as a general rule, there's no minimum interval, there's no maximum interval between doses. It's the minimum intervals that are the rate limiting step. I guess along with the question about immunogenicity after the second dose, in that interval after receipt of first dose before the second dose, is there any attenuation or partial protection from that first dose?
For B, we consider it to be none.
Dr. Lair.
So I want to thank the ACIP group for these comments because they're helpful for us as we move forward in the work group. A couple of thoughts. One, the age 11 dose has been a concern and has been brought up before. One of the pushbacks that has come up is it so low now because we've been vaccinating at age 11 since 2005. And so I think we need a little more data, and I'm going to ask Ms. Rubis to help us get that from before 2005. Was that also a nadir of the epidemiology? The other one, Dr. Maldonado, meningitis B is one of the least cost-effective vaccines that we have, with QALYs on the order of millions of dollars. And so when you look at this, these are considerations the work group has, and some people have brought that up, that we should just make this a routine recommendation, and that might be what the ACIP decides. But taking off my chair hat, I will never vote for that. It is simply not a good use of resources. And so if we're not going to have shared clinical decision-making and we're not going to have a routine recommendation, that's where the risk base is coming from. And so we are wrestling with all of these things in the work group, and if you have questions or if you have information that you're looking for that would help you make a decision when you're voting, that would help us in the work group. So thank you.
Dr. Lair, right quick, because I haven't seen these economic analyses, if the manufacturing company could lower the price, do you think it would be more feasible?
That is almost always true, but the one concern that we have is that this is literally a 1 in a million. There are 400 million people in the United States, and there's approximately 400 cases of meningitis in the whole country, let alone in the adolescent age group. So we are just talking such small numbers that it is very hard. Thank you.
Dr. Cotton.
I would like to clarify the language. Any adolescent who desires protection may receive vaccine. Are we now asking adolescents to make decisions on their vaccine needs? That seems unusual, and I worry about an equity piece because I think many of them will actually have their parents or others weighing in for them, and I wonder if I worry about the equity issues here. Thank you.
So we wrestled with the equity issues, and we were concerned that if we had risk-based as we have them planned, that people who did not fit into a risk-based group would not be eligible for the vaccine, and that would be inequitable in and of itself. And so we're looking for wiggle language that has been used in other cases. So you were correct that saying adolescent or guardian might be a better way of phrasing it, but you still have a question?
What about, so I like wiggle language. What about providing risk so the pediatricians actually know for whom this would be indicated, and then giving a little wiggle room where you could say adolescents who desire protection? That seems perhaps clearer. I don't know. I'm happy to hear from the pediatricians, of which I am not one.
So this is in addition to the risk-based language.
Okay, sorry, I didn't understand that.
Dr. Middleman, you've been very patient. Would you like to ask your questions or make a comment?
Yes, thank you very much. This is Amy Middleman from the Society for Adolescent Health and Medicine. I just want to briefly address two issues related to these recent discussions about meninge vaccine for adolescents. The first is related to the use of combination vaccines. Dr. Plotkin referred to the importance of their use yesterday in his comments. They are an evidence-based strategy that's been shown to improve adherence to vaccines, even with the addition of some antigens. We have an opportunity to use this strategy that's highly valued among infants and children for our adolescents, potentially with little economic cost. They would also address the complexity for providers in terms of stocking vaccines and registry confusion, in addition to addressing the threat of disease. We have not thus far optimized this strategy for our teens. These discussions also touch on another concern, which is the need to truly codify adolescent immunization platform visits. Immunization platform visits serve as the scaffolding on which to build multiple primary preventive interventions, including vaccines. They have remained relatively untouched for infants and children at the 2, 4, 6, 12 to 15 and months and 4 to 5 year visits. They create an expectation for immunization, serving as a cue to both families and providers. I would urge against eroding these relatively newer platforms for adolescents without very, very solid evidence. The elimination of effective vaccines that have been shown to save lives should not be undertaken without compelling data, especially in the face of shifting epidemiology of disease. The elimination of effective vaccines, as far as I can tell, has not previously been considered for the infant and childhood recommendations. Whether they are at the age of just learning to walk or at the age of just learning to drive, all of our children deserve the same thoughtful, consistent, evidence-based considerations for their health. Thank you.
Thank you very much. We have blown through our break, but I promise you still get one. We're going to do a 5-minute break before we start our respiratory syncytial virus session. So 10:20. I need the voting members to stop for a second and come back.
And I remember like getting the designation, special government employee, and I think that 34 meetings in 4 years probably designates you as a very special government employee. And so I wanted to thank you for that, all the amazing work. You've been through a lot, and I think every time the unmeasurable disease that we prevent because of vaccination happens, I think that you should all feel very, very satisfied in your contribution to saving lives and protecting people's health. Thank you.
Thank you. Should we do another round of applause? I feel like y'all need another round. Okay, on that note, Dr. Long, kick us off.
Yes, I am privileged to be able to introduce this session on behalf of the Maternal Pediatric Respiratory Syncytial Virus Disease Work Group. So there are 2 products recommended currently to protect infants and young children from lower respiratory tract disease due to RSV. For those in their first season to protect, there is both a single maternal RSV vaccine or the use of nirsevimab in the infant, and they are both either recommended. It is only under an extraordinary circumstance that an infant would have received both the maternal protection and their own. Additionally, children 8 to 19 months who are at increased risk of severe RSV disease and who are entering their second season are recommended to receive 1 dose of nirsevimab. Next slide, please. So here you'll see a very nice color-coordinated timing of these vaccines. Because these are both for the infant passive immunization, we recommended seasonal use of each. So in salmon is the maternal vaccine, which is recommended to be given to pregnant women at a certain time in pregnancy, only between September through January. And then for the infant, him or herself, between October through the end of March. For those born April through August, they would be entering their first RSV season as they were a little bit older, and they would be candidates and eligible for nirsevimab before 8 months of age. Next slide, please. So here this is written out for pregnant people at 32 through 36 weeks of gestation. Vaccine is recommended using seasonal administration, and for infants under 8 months of age, nirsevimab is recommended for seasonal use. And earlier in the season, obviously, would have the most benefit for those getting nirsevimab at 8 months, in addition to those who are born during the season. Next slide, please. As with all new vaccines and recommendations, and these being a little bit unusual recommendations, there are misadventures and vaccine administration errors. For our mothers and infants, these were a little bit unusual, although uncommon, because there were multiple products introduced in the same season, and just before this season, there was some confusion among healthcare workers as to which groups were eligible for which immunizations. And there were rare reports to VAERS of the following: reports of pregnant persons receiving the GSK vaccine during pregnancy, which trial was halted because of a statistically significant increase in premature births. So this was concerning that this vaccine, which was not recommended or licensed for use, was used in some pregnant people. And then reports of children receiving the adult RSV vaccine instead of the monoclonal antibody, which was both not studied in that age group and also would be a different dose than for an adult if it will be studied. So that was of concern. And then there were some wrong doses, as there's a cut point for 50 or 100 milligrams. The CDC then, COCA now, made additional resources available and increased education efforts with healthcare providers. Next slide, please. My lovely work group, first of all, the ACIP members, Dr. Brooks, Colton, and Dr. Jameson. And you'll see the liaisons from all of the stakeholders, the ex officio members, and several expert consultants helped us make some decisions. Next slide, please. And the CDC group, look at those. There are 10, 20, 30, 40, more than 40 CDC people contributed each one of these in different ways. But our leadership was phenomenal with Catherine Fleming Dutra and Jefferson Jones. Next slide, please. So the agenda today is implementation and uptake of nirsevimab and maternal vaccine. Then you will hear about maternal RSV vaccine safety surveillance, the summary of effectiveness of nirsevimab in infants, and the work group considerations in the next several months. And it's all good news. Sorry, stole your thunder. Let's move on then. Thank you.
Dr. Stokely. Thank you. I'm just waiting for the slides to come up. Okay, thank you. So good morning. As mentioned today, I'm going to be giving an uptake of maternal RSV vaccination and administration of nirsevimab for infants, as well as talk about some of the challenges we experienced with implementation from the previous season, and then our plans for the next season. So next slide. And next slide. Okay, so this slide shows the percent of pregnant persons ages 18 to 49 years that were vaccinated with RSV vaccine overall and by race and ethnicity. And so data are from the CDC's Vaccine Safety Data Link. Estimates of coverage are based on electronic health record data, and these come from multiple integrated health systems. And we see that from September through January, about 18% of pregnant persons were vaccinated overall. And vaccination coverage ranged from about 10% among Black pregnant persons to about 25% among Asian pregnant persons. And this pattern is fairly consistent with other vaccines during pregnancy, where we typically see highest coverage among Asian and white pregnant persons and lowest coverage among Black and Hispanic pregnant persons. Next slide. So this slide shows monthly nirsevimab receipt and intent among women 18 to 49 years who have an infant that is less than 8 months of age. And these data come from the National Immunization Survey Adult COVID module. And so looking at the most recent month of March 2024, we see that about 41% of infants were reported to have received nirsevimab. About 23% indicated they would definitely get nirsevimab for their infant. 24% indicated they probably will get nirsevimab or they were unsure. And about 12% indicated they probably or definitely will not get nirsevimab for their infant. Next slide. Okay, so using the data presented on the last two slides, we tried to estimate the proportion of infants that have some protection from RSV, either because of maternal RSV vaccination or receipt of nirsevimab. I'm not going to review all the methods on this slide, but it's here for your review. And will also be available in the slides that are placed online for ACIP. But the bottom line is that we estimate 51.2% of infants are estimated to have some protection from RSV, again, either for maternal vaccination or through receipt of nirsevimab, which is pretty good given this was our first year of implementation. Next slide. And so next we'll look at location of maternal RSV vaccine administration, and we have two data sources for this. The first one is IQVIA data, which projects estimates of vaccinations administered in pharmacies and in physician medical offices. It's important to note that this data source does not include pregnancy status, so we only have information on age group and sex. So here we're making the assumption that if a woman of childbearing age received RSV vaccine, it was because she was pregnant. And among the doses administered, 43% were in physician medical offices and 57% were in US retail pharmacies. The other data source we have also comes from the National Immunization Survey Adult COVID module. And in this survey, we do ask about pregnancy status, so we can limit our analysis to those who are pregnant. And among pregnant women less than 50 years of age that were surveyed between December 2023 and March 2024, about 5% reported they received the RSV vaccine, and 15% reported they received it in a pharmacy or drugstore, and 85% in a medical office. Next slide. So I know that estimates from the two different data sources are very different, so it's really important to consider these data in context of their limitations. I mentioned some of them already with IQVIA, but it's also important to note that the projected physician medical office estimates are based on a very small sample of physicians, and the data source doesn't include vaccinations that may be administered in other medical settings, such as public health clinics or other places. And then with the NIS data, the sample size is small, and we also don't know gestational age at the time of the interview, and so it's hard to know if all of those women would have been eligible for vaccination. Next slide. So now I want to shift to talking about implementation and some of the challenges we have, but then also our plans for the coming fall. Next slide. Again, this is a timeline showing our plans for vaccination availability. So maternal RSV vaccination will resume in most of the continental US starting September 1st. There will be limited availability of nirsevimab beginning in September, but the supply will ramp up and should be broadly available by October, so when most nirsevimab administration will begin. Next slide. So speaking about challenges from the past season, we know that because both maternal RSV vaccine and nirsevimab were new products, it does take time to integrate these products into systems and gain wide access and increase awareness among healthcare providers. Due to the timing of the licensure and launch, which occurred in August and September, that prevented some planning or advanced planning before the season began. Also, the clinical recommendations are complex, as mentioned earlier. There are different timeframes for maternal vaccination and nirsevimab, and it's also different from the timing for older adults for RSV vaccination. Additionally, the choice of one or the other can make communications difficult, and obstetricians in particular gave feedback that these conversations were difficult to have since infant immunization is not within their scope. And then there was some lack of awareness among healthcare providers. We received many complaints from pregnant people being turned away because they were told the vaccine was only recommended for older adults. And then there were challenges with the nirsevimab supply. And because of that, it was difficult to know where there was supply available and a feasible option in some places. So again, making that conversation about maternal vaccination versus nirsevimab even more difficult. And then there were issues with cost and reimbursement. We heard difficulties about with private health insurance not immediately covering the cost of the vaccine. And additionally, some Medicaid programs were slow to add maternal vaccination to their programs.
And then there tended to be a lack of supply of vaccine at many OBGYN offices early on. And additionally, some pharmacies required a prescription that included documenting that the pregnant person was between 32 and 36 weeks gestation, which also presents an additional barrier. And then there was lack of data on co-administration. Safety is one of the biggest concerns for pregnant people related to vaccination, and so the lack of data on co-administration can make pregnant people hesitant to get all the recommended vaccines at the same time, and thereby creating missed opportunities for vaccination. And then there are difficulties with electronic health systems. There's no ability to link maternal and infant immunization records, which then makes it difficult to determine if nirsevimab is needed. And we did hear reports of infants getting nirsevimab despite their mother getting RSV vaccine during pregnancy. And there were also concerns about safety and efficacy. Next slide. But despite that, we're happy to say that for this coming 24-25 season, there's no anticipated supply issues with the Pfizer vaccine. It should be, the Pfizer vaccine for adults should already be available in the field. But since maternal vaccination for some areas ended in January, providers who only vaccinate pregnant persons may need to rebuild their inventory. But plans are to have vaccine available so that vaccination can begin in September. Next slide. I also wanted to mention that CDC has launched a communication effort called From Me to You to raise awareness of the benefits and importance of vaccination during pregnancy, with a specific focus on outreach to Black pregnant people and their healthcare providers. And you can scan the QR code there to visit the website and see some of the materials that are available. Next slide. And so now I want to touch on some additional challenges that were experienced with the rollout of nirsevimab. I mentioned about the timing of the policy decision and how that left little time for planning. That also meant there was limited time for engagement with key stakeholders and partners to ensure healthcare workers were aware of the new product and the recommendations. Also, healthcare providers were uncertain of what the demand would be, given that private insurance companies have 12 months to adopt ACIP endorsed vaccines. And it turned out that demand was very strong, which was good. And many parents were actually willing to pay out of pocket for nirsevimab if insurance did not cover it. Next slide. Because of the insufficient supply to meet the demand from parents, clinicians were uncertain about how to ration or prioritize the few doses that they did have. We did issue an official health advisory notice via the Health Alert Network to prioritize available doses to high-risk infants and younger infants. By January, demand had decreased and additional supply was available, allowing return to original recommendations. Next slide. And so in order to prepare for the 24-25 season, CDC and FDA have been meeting regularly with the manufacturers since October to review the challenges from the last season and discuss planning for the next season. The manufacturer will be implementing significant steps to successfully support the coming season and to address the need for an overall increase in product, front-loading of product availability, and a revised mix of presentations. And taking these steps into account, particularly the timelines related to required regulatory approvals, the manufacturer's supply plan is to have limited availability starting in September, but then ramping up and having broad availability of the product by October 1st. And again, broadly available supply when vaccination begins is critical to promote confidence in vaccines and in our program. Promoting vaccination prior to the broad availability of supply does risk confusion and disappointment and decrease confidence in vaccines and among providers and the public. Next slide. One area I wanted to touch on is increasing access to nirsevimab. We have been working with state and local health departments to increase the enrollment of birthing hospitals to the VFC program, as this is an ideal setting for ensuring timely administration to eligible infants. And since July 2023, we have seen an increase in enrollment. Next slide. So to further increase hospital enrollment into the VFC program, we are engaging in data gathering activities, including conducting focus groups to identify the facilitators and barriers to enrolling hospitals in VFC, and also conducting a national survey of birthing hospitals. We're also planning activities to scale up enrollment, disseminating promising practices and success stories, and working closely with our immunization programs to track process and provide support. Additionally, we are also working to reduce enrollment burden. Programs can enroll birthing hospitals as a specialty provider, which allows the birthing hospital to offer only nirsevimab and hepatitis B vaccination at birth. Usually VFC providers, when they enroll, they agree to provide all ACIP recommended vaccines. So given the unique setting, allowing them to only offer nirsevimab and Hep B does reduce some barriers. And finally, we're collaborating with partners such as American College of Obstetrics and Gynecology, AAP, Association of Immunization Managers, and the Indian Health Service to increase enrollment and ensure there's broad access for this product. Next slide. So that concludes my talk, but I'm happy to take questions. Thank you.
Dr. Jameson.
Thank you. Thanks for a great presentation. And thanks to the incredible CDC team led by Drs. Fleming, Dutra, and Jones, and to Dr. Long as the ACIP lead for doing an incredible amount of work rolling this out successfully. And I'm struck by the number of challenges that this program has had. Just to name a few that have already been named, the reimbursement issues, the availability of the products, the complexity of the recommendations. It reminds me of the Group B strep recommendations when there were two sets of recommendations and it was very confusing for pediatricians and obstetricians. The silos in the healthcare system where we still can't effectively link maternal records with infant records, which has been an ongoing problem with pathogens for decades. And the communication, I think the communication issues have been really hard, especially for obstetricians who are trying to counsel about RSV and the lack of need for revaccination when we've spent a long time rolling out the Tdap recommendations where we say, this is primarily for the baby, this is not primarily for your protection, and so you need to be vaccinated, since the antibodies transfer, you need to be revaccinated with each pregnancy. So I think despite all of these challenges, I think the team has done a really good job because 50% of infants were protected last season. But I think this is a call to really figure out some of these implementation issues and get it way above 50% so that all infants can be protected. So thank you.
Thank you. Dr. Schechter.
Echo my thanks to CDC for all their efforts and to the presentation. Can you pull up slide 4 with the parental interest in nirsevimab? I think this is really powerful and important data, and the contrast between the 90% in the blue compared to the 30% production, or that gap between demand and supply this season. And it just makes me wonder if this data had been available in the prior year, would it have improved the situation or helped in the decision around production? I also wonder if 90% of the cohort supply could have been produced for the season, given, I think the estimate is 80% or something for this season. But and I don't know how many more situations we'll have like this in the future, but just to reiterate the importance of this data that CDC has collected around demand ahead of the launch of the product. The other quick observation is that we're trying in California as well to recruit our birth hospitals for nirsevimab, and have heard that there's apprehension around reimbursement for the private payer side, that even if they're getting free VFC vaccine, that if the product is available and well in pediatric care providers, that apprehension about the financial burden as the fixed birth hospitalization costs, the DRG or the bundled cost, has not yet been adjusted in many hospitals. Thank you.
Thank you, Dr. Daly.
Yeah, I mean, I'll start with a discouraging comment, but my overall sense is of optimism. But the discouraging comment is just that I think we anticipated high demand, and so I do still feel a sense of disappointment that there was not adequate supply, because I think talking to parents, talking to providers, anticipated really high demand for both products, but I'm speaking specifically to nirsevimab. So, and the shortage was so severe that the health advisory, although helpful, could not be implemented in regions who didn't even have enough product to implement the health advisory. So that's the more pessimistic comment. But I want to reflect on what we think this means in terms of hesitancy, what we think this means in terms of resilience of the National Immunization Program. And to that, I have a tremendous sense of optimism. In this context, acceptance was very high. And we may not see that with every disease, we may not see that with every vaccine, but in the context of us all getting discouraged, we're missing all of this opportunity for vaccine preventable disease prevention because of hesitancy. We need to say, in the right context, high level of acceptance across the board, and then we achieve tremendous disease prevention. Then in the context, so Dr. Stokely, your slides about challenges were they resonated because there were so many challenges. And despite that, more than 50% of infants last year were protected. That's a tremendous achievement that we need to keep in mind. We need to problem solve all the problems, but we need to have a sense of optimism about how much disease prevention, how resilient the system was. And I credit the CDC for that, so thanks.
Dr. Brooks.
Yes. First of all, thank you for the presentations, both of them, Dr. Long and the second one. So I was struck by, I think it's the slide right before this one, the disparities. 10.3 versus 24%. That's 2.5 times. So that's another barrier somewhere that we have to look at. But overall, I'm optimistic. Kind of, Matt was discouraged regarding that, the supply-demand imbalance. But if we got to 17% of pregnant persons, because often pregnant women are reluctant to get vaccinated because I'm pregnant, I don't know what's going to do to my baby. That's not bad. 50% nirsevimab, I don't even believe that. That's I think self-reported data. So I'll see when we have more clear data. But my question is the definition of a birthing hospital. Is that a hospital, any hospital where births take place? And then as a comment, so Dr. Schechter is in the state of California with me. I'm wondering how much outreach there has been to the hospitals. So first define if that's what it means to be a birthing hospital, and how much outreach as opposed to the hospitals coming to you.
Yeah, so thank you for that question. For the VFC program, it's broadly defined. It's could be a birthing facility, or birthing facilities to be inclusive of birthing hospitals and birthing centers. So I think it's where births are occurring, so it's very broad. And a lot of the outreach is being done by the state immunization programs, because they are the ones that implement the VFC program. And so they are the ones doing the outreach. It may vary state to state, but I think we all recognize the importance of these facilities to administer nirsevimab at birth for the eligible infants.
Yeah. Ms. Hayes?
Yes, Carol Hayes with the American College of Nurse Midwives. I was hoping that you could add us to your outreach group. And we also have very strong connections with the National Association of Birth Centers.
Thank you for that. Yes, we agree. You would be an important partner to include. Thank you.
Dr. Muniz.
Yes, good morning. Flor Munoz, representing IDSA. I just wanted to comment and ask a question regarding the coverage because due to the shortages, I think that this past season was not necessarily a typical season. We had to prioritize newborns and potentially the high-risk children. Certainly, this is something that was observed with nirsevimab in the MMWR report of initial effectiveness, that it was a lot of the higher-risk children. So I wonder if this number should really be including maternal vaccination plus dose at birth or prior to discharge from birth to really be comparable and to see what those numbers would be like. But I also wanted to ask you regarding the implementation and the timelines of September to January for the maternal vaccine and October to March for the nirsevimab. Given what was presented today in the implementation timeline and the fact that there are differences in the onset of the RSV season throughout the country, one of the barriers, I think, could be that the flexibility for sites or counties, states that have a different seasonality could potentially start earlier. And how could that be addressed so that the health departments and EFC programs and so on are able to allow these states like Texas or Florida to be able to start sooner? As an example, last year, certainly, it was a very short time and it was very amazing that we were able to implement it. But in Texas, for example, we had RSV already since September. And if we had started October, it would be too late for some of those babies being born then. So that's my main, request to see if there's any a way to address this difference in seasonality more specifically so that these states can start sooner than the overall general starting dates. Thank you.
Thank you. Dr. Lara and then Dr. Sineas, quickly so we can move on.
So for those of you who don't know how DRGs work, hospitals are paid a certain fixed sum for babies who are being born in the hospital, let's say $2,000. And when they are expected to add nirsevimab, which is $500, there's a 25% increase in cost, and they can't get reimbursed for it. So my question is, do we know if the DRGs have changed in the last year? Because my local hospital could not afford that, and so the vaccines were not, the nirsevimab was not given in the hospital last year for that reason. Thank you.
I'm not sure if our CMS liaison is on the line and perhaps could address this question.
I am on the line, but I have to apologize. I was multitasking and only heard part of the question. Could you repeat the question?
And this is actually more, not only CMS, but private insurers, do we know if the DRGs have changed to include nirsevimab as a routine cost for newborn care in the hospital?
So this is an ongoing question that we've been addressing, and I don't know that we have the exact answer. And actually, Shannon, do you have anything else that you want to share? Otherwise, we can follow up.
Yeah, we would have to follow up with you. I don't know the answer to that question.
Dr. Sineas.
Thank you. This is a question, I guess, for the manufacturer. Is the manufacturer considering flexibility in the dosing delivery? We had found ourselves with 100 milligram doses and with newborns that we were unable to give it to, and not having 50 milligram doses in the office. It would be helpful if there was some flexibility in terms of using 250 milligram doses or being able to split the products in order to maintain availability for our patients.
Yeah, hi, this is Chris Rizzo from Santa Fe Medical Affairs. At this time, we don't have approval to split hundreds. There's no indicator on the vial, and so that was not recommended. However, going into this season, we do anticipate having a better a mix of the 100s and the 50s available, and that providers can reserve the doses they need. And combining 250s for 100, we did receive that question as well. That, unfortunately, that would double the cost, and it's unlikely to be reimbursed, and so that's why that was not recommended. But we hope this year with our reservation program that we will better have a mix, and providers won't find themselves in that situation.
Thank you. Thank you so much. Let's move on to the RSV vaccine safety surveillance and the maternal vaccines. Dr. Morrow.
Okay, well, good morning. So I'll be discussing maternal RSV vaccine safety surveillance. The next slide, please. This is my disclaimer. The next slide. These are the topics that I'll discuss. I'll provide a background. I'll discuss the vaccine safety monitoring systems used for the Pfizer RSV vaccine in pregnancy. That's the vaccine adverse event reporting system, the BSafe, and the vaccine safety data link. The next slide, please. So some key points. In the clinical trials among pregnant persons, more preterm births were noted among Pfizer RSV vaccine recipients compared to placebo, but the difference was not statistically significant. Post-licensure safety surveillance of the Pfizer RSV vaccine in pregnant persons was initiated during the current season, and the patterns of reported local and systemic symptoms in BSafe and bears after the maternal Pfizer RSV vaccine were consistent with the pre-licensure safety profile. Among pregnant persons received in bears after the maternal Pfizer RSV vaccine, the most frequent adverse events reported were frequent pregnancy-specific conditions, as expected for a vaccine recommended at 32 to 36 weeks gestation. Preliminary findings in the BSD observed that the incidence of preterm births is 4.1% among pregnant persons who received the Pfizer RSV vaccine during the current season. The next slide, please. So as I mentioned, the clinical trials of the pregnant persons show that there were more preterm births after the Pfizer RSV vaccine compared to placebo. And to avoid the potential risk of preterm birth before 32 weeks gestation, FDA approved the maternal Pfizer RSV vaccine for use in pregnant persons at 32 through 36 weeks gestation. Now, the label for the Pfizer RSV vaccine notes the potential risk of preterm birth under the warnings and precautions section. The next slide, please. So I'll start with describing some data from bears, the vaccine adverse event reporting system, which is the national spontaneous surveillance system used to monitor the safety of all U.S. licensed vaccines. Bears is co-managed by CDC and the FDA, and it was created in 1990. The next slide, please. And it has a number of strengths and limitations. An important limitation is that it's not designed to assess for causality. The next slide. So this slide shows some approaches used to analyze bears data as it pertains to vaccines recommended in pregnancy, and there are a number of vaccines that have been monitored using bears, such as influenza, Tdap, COVID-19. And the analysis include a descriptive analysis, clinical review of individual reports, aggregate descriptions of automated data, and calculation of reporting rates for pregnancy outcomes. And for this vaccine, we're also conducting a clinical review of infants' medical records at birth and during the first months of life. So this is a type of enhanced surveillance. The next slide. So this slide shows the characteristics of the maternal Pfizer RSV vaccine reports submitted to bears. So a total of 121 reports have been received in bears, and there have been no maternal deaths. And if you'll note, in terms of the type of reporter, the patient is, or the pregnant person is the one that reported in most cases with, in 60 reports out of the 121, that's 50%. Next slide. So this slide shows the most frequently reported meta-preferred terms among reports to bears. And just to know that this is automated data. So these are MEDRA preferred terms or codes. And the most common preferred term being reported is premature delivery in 29 reports or 24%. The next slide. So this slide shows the adverse events among pregnant persons following the Pfizer RSV vaccination. And this is based on clinical review. And because of that clinical review that involves reviewing the birth report and also any associated medical records, you'll know that the numbers are a little bit different than the previous slide. So for example, the one condition most commonly observed is premature delivery in 37 reports of 31%. There was one infant death. And in terms of non-pregnancy specific conditions, the group with most reports, general disorders and administration site conditions, accounted for 41 reports or 34%. That's composed mostly of injection site and systemic reactions. There were 2 reports of Bell's palsy, but no reports of verified Guillain-Barré syndrome. And the next slide. So this slide shows the some characteristics of the preterm deliveries. So out of 37 premature deliveries, 27 occurred in late preterm, between 34 and 36 weeks. 22 reported a medical condition or complication that increased the risk for preterm delivery. The next slide, please. So this slide shows the characteristics and outcomes of infants born to Pfizer RSV recipients. So a total of, we have information on a total of 75 infants, and we're waiting for additional information for the other 46. Premature birth was observed in 38 or 51%, and just to know that the infant, there was one infant, the one infant death is the same one that I mentioned before in that previous table. And there were 16 reports of 21% that were born with low birth weight. And 24 reports, the infant required admission to the neonatal intensive care unit. And the condition or reason for admission to the NICU is noted in the slide. The next slide, please. So in summary, for bears, among reports received, local and systemic symptoms were frequently reported in bears after the Pfizer RSV vaccine, consistent with pre-licensure studies in pregnant persons. In clinical trials among pregnant persons, more preterm births were noted among Pfizer RSV vaccine recipients compared to placebo. The label for Pfizer RSV vaccine notes the potential risk of preterm birth under warnings and precautions. Now the patients, the pregnant person herself, were the most common reporters in 50% of reports overall, but they represented 70% of those who reported a preterm delivery. So reports of pregnancy-specific conditions were not unexpected for the Pfizer RSV vaccine, which is recommended at 32 to 36 weeks gestation. The next slide. So now turning to BSafe. So BSafe is a system that was developed to monitor the safety of the COVID-19 vaccines. The next slide, please. Okay, yeah, this is fine. So the BSafe was created to monitor the safety of the COVID-19 vaccines, and it was then adapted for other vaccines, for example, for monkeypox, and now for the maternal Pfizer RSV vaccine. This is a telephone-based system where text messages are sent to the vaccine recipients with inquiries about the type of reaction experienced. And so the system collects information on local reactions, systemic reactions, and also health impact information, such as any missed work, or if the patient required a visit to the doctor. And there may be also additional questions on, such as history of premature delivery. The next slide, please. So, so far, BSafe has collected information on 1,116 pregnant persons. So this is some data on these participants. The next slide, please. So this other slide shows some of the reactions and health impacts that these patients have experienced, have reported. You'll note that injection site reactions and systemic reactions accounted for a little more than 30% of reports, but very few require medical care. The next slide. So turning now to the vaccine safety data link, the next slide. So the BSD is a collaboration between CDC and 9 healthcare organizations, which provide healthcare to a population of about 15.5 million individuals. The next slide. So in the BSD, the BSD has assessed the cumulative, the historical incidence rates of preterm birth among pregnancies during the period from 2017 to 2022. So this is a period before the Pfizer vaccine, the maternal Pfizer vaccine became available. They have also determined the incidence of preterm births in RSV vaccinated pregnant persons. The next slide. So this slide shows, on the top, that graph shows the incidence of preterm births among pregnancies in the BSD during the period from 2017 to 2022, again before the Pfizer RSV vaccine became available. And the average preterm birth incidence was 4.4%. Now at the bottom you see the incidence, the incidence of preterm birth in vaccines recipients of the maternal Pfizer RSV vaccine, and that incidence is 4.1%, which is within the expected range based on historical data. The next slide, please. So BSD is currently conducting a match analysis, and they are looking at some outcomes which are shown in the slide, and that includes preterm birth. And it is expected they'll have some data available later this year. The next slide, please. So in summary, local and systemic symptoms were reported to be safe following Pfizer RSV vaccine in pregnant persons with a frequency similar to that observed in pre-licensure trials. A few pregnant people in BSAFE reported medical care for symptoms. Among reports received in bears after the maternal Pfizer RSV vaccine, the most frequent adverse events reported were local and systemic symptoms and pregnancy-specific conditions, as expected for a vaccine recommended for pregnant persons. And post-licensure vaccine safety data from bears and BSAFE during this first season after maternal Pfizer RSV vaccine are consistent with the pre-licensure safety profile. Preliminary findings in the BSD observed that the incidence of preterm births is 4.1% among pregnant persons who received the Pfizer RSV vaccine during the current 23-24 respiratory season. And CDC and FDA will continue to monitor maternal RSV vaccine safety in bears, BSAFE, and the BSD. I'd like to end by thanking several collaborators from the Immunization Safety Office, our friends at the Food and Drug Administration, and also at the National Center for Immunization and Respiratory Diseases. I'll be happy to take any questions.
Thank you, Dr. Cotton.
Thank you very much for that nice presentation and the excellent attention to safety data. I did a little bit of a calculation because I think one of the bottom lines for the public listening might just be what's the overall risk? And it looks like to VAERS, there were 121 reports out of 222,000 vaccines given, so perhaps an adverse event rate reported to VAERS of 1 in about 1,800 or 0.5%, so overall very low and safe. Would you agree with that?
Well, the number of reports is actually, the number of reports that VAERS has received is relatively low. But I think even though it's kind of low, it's reassuring in that this is I mean, we observed some reports of preterm delivery, but this is a vaccine that had some where there was a signal in the clinical trials that showed that there were more premature births among vaccine recipients. So this is something that we knew about. It was not something unexpected. That's what I'm trying to say.
Thank you.
Dr. Daly.
Yeah, thanks so much. I just want to raise one point that maybe Dr. Jamieson and Dr. Morrow could address, which is that I think in this room we're all familiar with seeing VAERS data and then interpreting it in the context of the system. But when we see a neonatal death, that is, of course, devastating for that family, but reporting to VAERS does not necessarily mean that vaccine caused that. And so if we could just comment on that and make that clear. Thanks.
Yes, that's correct. We don't assess causality in VAERS, but yeah, I mean, we of course will continue to monitor for any especially serious adverse events such as an infant death, and but with few numbers, it's difficult to reach any conclusion. We just have to keep monitoring and make sure that it's nothing unexpected gets reported.
Dr. Jamieson, and then we'll move on due to time.
I had two questions. I missed the details. Did you give any details about the infant death? And number two, could you clarify, you said there was a safety signal in the clinical trial. Was that statistically significant?
I was referring, with regards to that, I was referring to the observation that among in the clinical trials, in the pre-licensure clinical trials, before the vaccine was recommended, there were more premature births among vaccine recipients compared to placebo. Now, sorry. Let me show you the slide of the clinical trial. So this is the finding in the clinical trial, and the difference. Oops.
Could you advance the slide one more?
Can we go to the last? Can we go to the last slide? To slide 26, I believe it is. Yes. Yes. So here we see the preterm birth rate in the vaccine group was 5.7% compared to the placebo group, 4.7%.
And this is Dr. Fleming-Dutra, one of the work group leads. And to answer your question, to clarify, again, in the Pfizer phase 3 trial, this difference was not statistically significant between the vaccine and placebo groups regarding preterm birth.
Thank you. And then I just, rather than go into the details about the infant death, I just wanted to emphasize, I think it was an anoxic brain injury.
Yes, that's correct. It was an infant with anoxic brain injury, yes. And
just to clarify, as an obstetrician, the likelihood of that being directly related to vaccine administration is extraordinarily low. There are so many causes of that type of death, mostly related to other issues not related to vaccine. So I think it's critically important, and I congratulate your group on continuing to monitor safety issues and look forward to future presentations. So thank you.
Okay, thank you.
Thank you. Dr. Payne, why don't we talk about the effectiveness of nirsevimab?
Okay. We'll wait for the slides to come up. There we go. Good morning. I'll be giving an update on effectiveness of nirsevimab in infants. Next slide, please. So today I will review real-world vaccine or product effectiveness methods. Then I'll give an update on effectiveness of nirsevimab from 2 US-based platforms. I'll review what we know about effectiveness of nirsevimab from other countries. And finally, I'll summarize with some conclusions. Next slide, please. So first, let's quickly review some real-world vaccine or product effectiveness context and methods. Next slide, please. A version of this slide was presented during previous sessions. Efficacy is the degree to which an immunization prevents disease under ideal and controlled conditions. Efficacy is generally what we're measuring in clinical trials. Effectiveness, on the other hand, is the degree to which an immunization prevents disease under real-world conditions. Effectiveness is generally what we're measuring in post-licensure observational studies. In this presentation, we will be discussing nirsevimab, or product effectiveness from real-world data. Next slide, please. Real-world data regarding effectiveness are needed because, as you all are well aware, the real world isn't as controlled as the setting of a clinical trial. In the real world, immunization status isn't assigned randomly, and factors related to who received immunization versus who didn't can bias product effectiveness estimates. In October, CDC released an official health advisory to provide recommendations for prioritizing doses of nirsevimab in the context of a shortage of the doses during the 23-24 RSV season. By January, demand had decreased and additional supply was available, allowing return to the original recommendations. However, this shortage during the early parts of the 23-24 RSV season likely influenced distribution of nirsevimab. Next slide, please. There are a variety of study designs we could employ to measure effectiveness under real-world circumstances. The two platforms I will be discussing today use the test negative design, or TND. As a reminder from yesterday, in this design, persons with acute respiratory illness who present to care and are tested for RSV are included. The odds of immunization among those that are RSV positive or cases are compared to the odds of immunization among those that are RSV negative or controls, with effectiveness being calculated as 1 minus the odds ratio times 100%. The benefits of a TND are that this design reduces bias from healthcare-seeking behavior by including cases and controls who present to care and receive testing. For example, persons with high-risk conditions may be more likely to seek care for RSV-like illness than those without these conditions. A TND can help control for these behaviors. There are, however, some considerations. The validity of effectiveness estimates from TND studies can be dependent on sensitivity and specificity of diagnostic testing. Additionally, residual confounding is possible, and care should be taken to account for potential confounders in the data collection and final analysis. Next slide, please. The first platform I will be giving an update from is the Virtual SARS-CoV-2 Influenza and Other Respiratory Viruses Network, or VISION. Next slide, please. As you've heard in other presentations this week, VISION is an electronic health records-based platform. For pediatric product effectiveness work, VISION leverages data on emergency department encounters and hospitalizations for RSV-like illness from 127 emergency departments and 107 hospitals that provide pediatric care. Infant and maternal RSV immunization status are documented by electronic health records, state and city registries, and for a subset of sites, insurance claims data. Covariate data, such as underlying medical conditions and patient characteristics, are documented by electronic health records. Next slide, please. This slide shows the distribution of ED encounters and hospitalizations for RSV-like illness among infants in their first RSV season by immunization and RSV positivity status in VISION during the 2023-2024 RSV season. Next slide. RSV activity peaked in late December or early January. Next slide. Very few encounters had evidence of maternal RSV vaccination, represented in the orange dots at the top of the plots, likely due to the low maternal RSV vaccine coverage during the 2023-2024 RSV season. Furthermore, the majority of these encounters occurred in the latter part of the season. Next slide, please. There were more encounters with evidence of nirsevimab administration, and these encounters were seen throughout the study period, with more encounters with a negative RSV test compared with a positive RSV test. Next slide, please. A TND analysis of first season nirsevimab product effectiveness against RSV-associated ED encounters and hospitalization were conducted in VISION. In this analysis, infants aged less than 8 months as of October 1st, 2023, or those born after October 1st, 2023, who visited a participating ED for or were hospitalized with RSV-like illness, or RLI, and were tested for RSV were included. Cases were those with RLI and a positive RSV antigen or NAT test, and controls were those with RLI and a negative RSV NAT test. Encounters during October 8th, 2023 through March 31st, 2024 were included. Encounters were excluded for the reasons listed on the slide. And the adjusted odds ratio, comparing the odds of immunization among the cases versus the controls, was estimated using multivariable logistic regression. And product effectiveness, or PE, was calculated as 1 minus the adjusted odds ratio times 100%. Next slide, please. This slide outlines findings from the assessment of the first season nirsevimab product effectiveness in VISION. These results indicate nirsevimab was effective against RSV-associated ED encounters and hospitalization among infants in their first RSV season. The top portion of the table outlines the results of the assessment of nirsevimab effectiveness against RSV-associated ED encounters. Among about 5,000 ED encounters for RSV-like illness, among infants in their first RSV season, 442 had evidence of nirsevimab receipt 7 days or more prior to the encounter, with a median time since dose of 53 days. RSV percent positivity was lower among those that had evidence of nirsevimab receipt compared with those without, and the adjusted estimate of product effectiveness was 77%, with a confidence interval from 69% to 83%. The bottom portion of the table outlines the results of the assessment of nirsevimab effectiveness against RSV-associated hospitalization. Among 1,000 hospitalizations for RSV-like illness in the infants in their first season, 93 had evidence of nirsevimab receipt, with a median time since dose of 48 days. Similar to what was seen for ED encounters, RSV percent positivity was lower among those that had evidence of nirsevimab receipt compared with those without. The adjusted estimate of product effectiveness against RSV-associated hospitalization was 98%, with a confidence interval from 95 to 99%. Next slide, please. Next, I'll give an update from the new Vaccine Surveillance Network platform. This is an update to data that were published in CDC's Morbidity or Mortality Weekly Report this spring. Next slide, please. NVSN is a prospective population-based surveillance network for pediatric acute respiratory illness, or ARI, at 7 U.S. medical centers. Children less than 18 years of age with ARI are enrolled year-round in outpatient, urgent care, ED, and hospital settings, with goals of determining the etiology and burden of laboratory-confirmed acute viral respiratory disease in children, characterizing the clinical and epidemiologic factors of pediatric ARI and associated syndromes, and evaluating vaccine or product effectiveness using a test-negative design. Next slide, please. Data collected for NVSN involves a caregiver interview, collection of mid-terminate nasal swabs from all enrolled children for RSV testing, and sequencing of RSV-positive specimens to monitor for substitutions in the nirsevimab binding site, and medical chart abstraction. Immunization status is ascertained by parent report and confirmed with State Immunization Information System, electronic health record, and birth record review. Next slide, please. This slide shows the distribution of RSV detections among infants in their first RSV season in NVSN during April 2023 through April 2024, overlaid with timing of RSV product availability and timing of product receipt among infants enrolled in NVSN. All NVSN sites had some nirsevimab availability by mid-October. Among 2,383 infants in their first RSV season, 11.1% had received nirsevimab, 2.2% had received palivizumab, and 3.4% of eligible infants had evidence of maternal RSV vaccination at the time of their ARI encounter. Next slide, please. Similar to what was seen in VISION, encounters with evidence of nirsevimab receipt were seen throughout the RSV season. Next slide, please. The majority of infant encounters with evidence of maternal RSV vaccination occurred during a time of declining RSV activity. Next slide, please. A T&D analysis of first season nirsevimab product effectiveness against medically attended RSV-associated ARI episodes and RSV-associated hospitalization, a subset of medically attended ARI episodes, was conducted in NVSN. In this analysis, infants aged less than 8 months as of October 1st, 2023, or those born after October 1st, 2023, with ARI were enrolled from participating sites. Cases were those with ARI and a positive RSV test, and controls were those with ARI and a negative RSV test. Encounters during October 2023 through March 2024 were included. Children were excluded for the reasons listed on the slide, and the adjusted odds ratio comparing the odds of immunization among the cases versus the controls was also estimated using multivariable logistic regression, with product effectiveness being calculated as 1 minus the adjusted odds ratio times 100%. Next slide, please. This slide outlines findings from the assessment of first-season nirsevimab product effectiveness in NVSN. Similar to findings from VISION, nirsevimab was effective against medically attended RSV-associated ARI episodes and RSV-associated hospitalization. The top portion of the table outlines the results of the assessment of nirsevimab effectiveness against medically attended RSV-associated ARI episodes. Among nearly 1,700 ARI episodes and infants in their first season, 120 had evidence of nirsevimab receipt, with a median time since dose of 42 days. RSV percent positivity was lower among those that had evidence of nirsevimab receipt compared with those without, and the adjusted estimate of product effectiveness was 89%, with a confidence interval from 77% to 94%. The bottom portion of the table outlines the results of the assessment of effectiveness against RSV-associated hospitalization. Among 870 hospitalizations for ARI among infants in their first season, 63 had evidence of nirsevimab receipt, with a median time since dose of 38 days. Similar to what was seen for medically attended episodes overall, RSV percent positivity was lower among those that had evidence of nirsevimab receipt compared with those without, and the adjusted estimate of product effectiveness was 91%, with a confidence interval from 79% to 96%. Next slide, please. Next slide, please. Observational data from the United States compared with data from randomized clinical trials indicate nirsevimab is working as expected during the first season after approval among infants in their first RSV season, with effectiveness estimates well above 50%. Next slide, please. There are some limitations to keep in mind when interpreting findings from U.S. observational data. First, the high product effectiveness estimate should be interpreted with caution. There was a short interval from nirsevimab administration to respiratory illness onset, and these investigations were unable to assess duration of protection. Second, while the TND can help control for health-seeking behavior, residual confounding was possible, although a variety of sensitivity analyses were performed to assess the influence of suspected confounders. Third, misclassification of RSV immunization status was possible, although a variety of sources were leveraged to determine immunization status. Fourth, these results only reflect product effectiveness among infants in their first RSV season and may not reflect effectiveness among children at increased risk in their second RSV season. Specific to VISION, cases may have sought care for something other than RSV. All RSV testing was clinician-directed, and EHR data may not fully capture all underlying medical conditions. And specific to NVSN sites are academic pediatric medical centers with catchment areas and hospitalization acuity that may not be nationally representative. Next slide, please. Next, I will give an update of what we know about nirsevimab effectiveness from published literature. Next slide, please. There have been several studies regarding nirsevimab effectiveness against a variety of outcomes published in the last year, largely from European countries. Similar to findings from the United States, nirsevimab has been shown to be effective against RSV-associated hospitalization and emergency department encounters among infants, with estimates of effectiveness against RSV-associated hospitalization ranging from 70% to 89%, and estimates of effectiveness against RSV-associated ED encounters ranging from 55% to 88%. Next slide, please. Next slide. Together, these data indicate nirsevimab was effective against RSV-associated ED encounters and hospitalization among infants in their first RSV season during the 2023-2024 RSV season. However, due to the timing of authorization and recommendations of RSV prevention products and RSV activity during the 2023-2024 season, these results should be interpreted with caution. US-based analyses may be subject to residual confounding due to the prioritization of nirsevimab doses, and the short time between nirsevimab administration and outcomes limits the ability to assess duration of protection. Further, there was limited ability to assess effectiveness of maternal RSV vaccines during this past season. CDC will continue monitoring post-licensure product effectiveness. Next slide, please. I want to acknowledge the host of people that contributed to this work. It's truly been a team effort. Thank you, and now I'll pause for questions.
I'm going to take chair's prerogative and make a statement. Even with caution, these results are astounding. I mean, it is phenomenal. A vaccine in this young group for a viral respiratory disease would not have anywhere near the effectiveness that this has. We've heard several comments about payer issues, and I'm from a southern state, and we start early with RSV, so we may fall within that 12-month window that some feel like they have. I would just find it absolutely negligent, based on this data, not to go ahead and pay for this. This is unbelievable and is life-saving and life-changing, and it's just fantastic. Thank you. Dr. Schechter.
Thank you. I share your excitement, enthusiasm, and appreciation. Is it known within the VISION sites whether the population receiving nirsevimab was more likely to be high risk given the supply shortage? I guess, can we make any assumptions about whether these results were in a higher risk population, as a first question? Second question, you had maternal RSV receipt in the VISION slides, and will there be outcome data coming soon, or do you have data on the effectiveness of prenatal immunization? I'll start with those. Thanks.
Yeah, thanks for your question. So can I get slide 37? Maybe 38. Actually, can you go one more slide forward? Thanks. So these are data from VISION. I know it's a busy slide, but you can sort of see the data that we collected in terms of risk conditions. And so just to orient you, the left-hand side is among ED encounters, the right-hand side is hospitalizations, and then we've split it out by case control status and then nirsevimab status. So we did, I will just back up and say, we did look at whether accounting for any of these characteristics changed our estimates, and they didn't. But we will certainly continue collecting these data and monitoring whether that makes a difference in the next season. And then to your second question, yes, we will continue monitoring effectiveness in next season and hope to collect more data on maternal RSV vaccination next season as well.
One last question. With the numbers you had, was there any, were you able to detect any effect in duration since receipt? Was there any suggestion of waning over time after receipt, or compared to the 5-month estimate of protection from licensure?
Yeah, thanks for that question. We were not able to assess duration of protection this season, but we will continue monitoring and hope to be able to address that question in the next season.
Thank you, Dr. Jones. Oh, sorry, Dr. Long.
We did see, Rob, in the data from the manufacturer that there is not significant waning in the first 6 months. So this is very highly expected to provide protection through the first season. And to answer Dr. Jameson's questions, just so that you'll have a little bit more background about this, the trials that showed an imbalance were done in multiple countries, and they were in gestational ages beginning at 24 weeks, which was the intended licensure at that time. And the premature births were different by country, but the p-value, as I remember, was about 0.1. So I remember thinking there's still only a 10% chance that this is just chance alone. So we were very concerned about that, and we were very grateful that the FDA saw to restricting the licensure from 32 to 36 weeks. We also saw with that something that made you wonder a little bit about plausibility or maybe a different mechanism. It was definitely, the premature births were not associated with increased reactogenicity in the mothers, and it tended to occur about 4 weeks after the vaccination. So we were really comfortable, or we would have had the discussion here, and we would have, as a work group, restricted it to probably the same gestational age, but we were very grateful that the FDA wore their big shoes and took that on.
All right, last question, Ms. DeShawn.
Yeah, hi, Dana DeShawn from National Association of Pediatric Nurse Practitioner. Thank you for those presentations. It's very reassuring. I know our facility that I work with didn't get the nirsevimab until late, and then we had an abundance. We were trying then to give to those infants. I guess my comment is just now that we have 2 RSV vaccines and the antibody, it's just that whole safety to making sure that we're giving it to the right people at the right time. And yes, we do need to look at that seasonality, but I guess my concern would be that we give that maternal RSV vaccine too early. I have a coworker who's a nurse that just got her vaccine, and our RSV season is not until usually October. So getting those at pharmacies or at family practices or the OB offices to make sure that we're giving it to those right individuals at that right time. So we're not leaving those infants at risk late in the RSV season. And then also encouraging them to be part of the pregnant women to be part of that V-Safe participation for ongoing surveillance. Thank you.
Thank you for those comments, and I wanted to mention earlier that the recommendations, I didn't read the bottom line, which is for both nirsevimab and vaccine, the local epidemiology of RSV is to be taken into consideration, and there couldn't be variations from the October through March and the September through January. So thank you.
All right, Dr. Jones, you ready for work group considerations?
Yeah, thank you. Next slide. So on behalf of the Maternal Pediatric Work Group, today I will discuss the work group considerations regarding the anticipated supply of maternal RSV vaccine and nirsevimab for the 2024-25 RSV season, then give updates on post-introduction nirsevimab and maternal RSV vaccine safety and effectiveness monitoring considerations and interpretation, and then finally discuss some clinical considerations for revaccination of pregnant people who received maternal RSV vaccine and for subsequent pregnancies. Next slide. So as presented by colleagues earlier in the discussion, for maternal RSV vaccine, there is no anticipated supply-demand mismatch. For nirsevimab, limited availability is expected in early September, with supply ramping up during September, and nirsevimab should be broadly available by October 1st. The original ACIP recommendations, as published in the MMWR, apply for the 2024-25 RSV season. Recommendations to prioritize doses of nirsevimab for those at highest risk of disease, as mentioned in a health alert in October 2023, do not apply. So all infants are recommended to be protected by either maternal RSV vaccination or nirsevimab for the 2024-25 RSV season. Next slide. Next slide. Next, for maternal RSV vaccine safety, as presented, among reports received in VAERS after maternal Pfizer RSV vaccine, the most frequent adverse events reported were local and systemic symptoms such as headache and pregnancy-specific conditions such as preterm delivery, and reports of pregnancy-specific conditions as expected for vaccine recommended for pregnant people at 32 through 36 weeks gestation. And of note, there were no verified reports of Guillain-Barré syndrome among pregnant people. Preliminary findings in VSD suggest that the incidence of preterm births is 4.1% among pregnant persons who received Pfizer RS vaccine during the 2023-24 RSV season, and this is within VSD's expected historical range of the incidence of preterm births at 32 through 36 weeks gestation, being 3.1 to 6.1%. Among pregnant people before introduction of this vaccine. And these results are preliminary, and a matched analysis for preterm birth and other safety outcomes is in progress. Next slide. So VAERS is not the primary system for monitoring nirsevimab safety, which is classified as a drug and not a vaccine. So these have not been previously presented today, but suspected adverse reactions after nirsevimab administration are recommended to be reported to MedWatch, which is part of the FDA Adverse Event Reporting System, or FAERS with an F. If administered on the same day as a vaccine, suspected adverse reactions after nirsevimab administration are reported to VAERS, and then FDA reviewers review these VAERS reports. Similar to VAERS, an incidence of an adverse event cannot be determined from voluntary reporting. Next slide. So to summarize, nirsevimab post-marketing adverse events reported into FAERS, the most frequently reported adverse events involved patients who developed breakthrough RSV infections despite receiving nirsevimab, and included signs, symptoms, or complications of these infections, such as bronchiolitis. Cases of serious hypersensitivity reactions with nirsevimab were identified in the post-marketing setting, and the product labeling was updated in February 2024 as follows. Serious hypersensitivity reactions have been reported following Beyfortus administration. These reactions include urticaria, dyspnea, cyanosis, and/or hypotonia. And no additional safety signals have been identified at this time. Next slide. After reviewing the maternal vaccine and nirsevimab safety data, workgroup considerations included that safety data on nirsevimab maternal RSV vaccine are reassuring. However, population-based studies with comparison groups are needed, and these studies are currently pending. It was noted that because of the U.S. recommendation that Pfizer maternal RSV vaccine be given at 32 through 36 weeks gestation, we are unlikely to accumulate U.S. data on the safety of the maternal RSV vaccine given at 24 through 31 weeks gestation. And the potential risks of a vaccine given at 24 through 31 weeks gestation differ from those when given at 32 through 36 weeks gestation. Regarding the hypersensitivity reactions in young infants, it was noted by the work group that in general, hypersensitivity reactions in young infants are rare and can be difficult to discern from startle reactions or vasovagal reactions following immunizations. Next slide. Regarding nirsevimab effectiveness against RSV-associated hospitalizations was 91% in MVSN and 98% in VISION as presented. Effectiveness against any medically attended RSV acute respiratory illness episode in MVSN was 89%, and effectiveness against RSV-associated ED visits was 77% in VISION. These CDC platform estimates are consistent with studies from Europe, and additional studies with longer follow-up time are needed to determine the duration of protection. In the United States, there was limited impact of RSV immunization on the burden of RSV hospitalizations during the 23 to 24 season, and this was likely because of late administration of the immunization products. In contrast, substantial decrease in RSV-associated hospitalizations in young infants have been reported in Spain, Luxembourg, and Italy that were associated with early implementation and high nirsevimab coverage. Next slide. CDC platforms were unable to estimate maternal RSV vaccine effectiveness during the 23-24 RSV season due to limited uptake of maternal RSV vaccine, relatively early onset of the 2023-24 RSV season, combined with the timing of the vaccine rollout. And CDC will continue to monitor maternal RSV vaccine effectiveness in future seasons. Next slide. So workgroup considerations on effectiveness include that, similar to remarks expressed today, they were very happy and pleased with the evidence that shows nirsevimab to be highly effective. that the duration of protection from nirsevimab and maternal vaccination remains unknown, and important studies are needed for the 2024-25 RSV season and future RSV seasons, including studies on maternal vaccine effectiveness, nirsevimab effectiveness with longer follow-up time, which should be available with earlier widespread availability, nirsevimab effectiveness among children aged 8 through 19 months with increased risk for severe disease during their second RSV season, and on the impact on RSV burden in the United States when nirsevimab and maternal vaccine are given with early administration and potentially increased uptake. Next slide. Next slide. So ACIP recommendations for Pfizer maternal RSV vaccine published in 2023 state that currently no data are available on either the efficacy of the first lifetime dose to protect infants born after subsequent pregnancies or the safety of additional doses given during subsequent pregnancies. Additional data are needed to determine whether additional seasonal doses during subsequent pregnancies are indicated, and ACIP might update recommendations in the future as data become available. So currently, there's still no data on additional RSV vaccine doses in subsequent pregnancies. However, there are potentially people who received an RSV vaccine during pregnancy for the 23-24 RSV season who could have a subsequent pregnancy during the 24-25 RSV season. Next slide. Pertinent data include the slide shared 2 days ago showing RSV vaccine efficacy against lower respiratory tract infection over 2 RSV seasons among adults aged 60 years or greater. And for both the trial outcomes of RSV LRTI, the efficacy was lower during the second RSV season than during the first RSV season, showing that protection decreased over time. Next slide. Displayed is Pfizer's RSV vaccine phase 1/2 study that measured immunogenicity results in non-pregnant adults, including those aged 18 through 49 years. In the figure at the bottom, geometric mean neutralizing antibody titers against RSV-A and RSV-B are shown on the left and right respectively, and this study had 5 arms involving those with and without an adjuvant in the RSV vaccine and with and without concurrent flu vaccination. But importantly, in all arms with revaccination with the RSV vaccine, the antibody titer is lower following the second dose at 12 months than the initial response after the first dose. The antibody titer just prior to the second RSV vaccine dose was above baseline. Next slide. So also of note is ACIP has recommended Tdap during each pregnancy. ACIP Tdap recommendations state, when ACIP considered recommending Tdap vaccination during each pregnancy, the safety information concerning booster doses of Tdap in pregnant women previously vaccinated with Tdap was not available. And it later states that ACIP recognized the need for safety studies of severe adverse events when Tdap is administered during subsequent pregnancies, but concluded that the potential benefit of preventing pertussis morbidity and mortality in infants too young to be fully vaccinated outweighs the theoretical concern of possible localized severe adverse events in pregnant women receiving Tdap. Next slide. The ACIP RSV maternal pediatric work group has discussed additional RSV vaccine doses in subsequent pregnancies. The work group felt it is concerning that data in older adults suggest revaccination does not restore antibody levels to those after the first dose, and antibody levels are particularly important for maternal vaccination since infants are protected through transplacental transfer of antibodies. Additionally, the RSV vaccine differs from Tdap vaccine. The maternal RSV vaccine has a potential safety concern for preterm birth and hypertensive disorders of pregnancy, as discussed earlier today. And an alternative product, nirsevimab, exists that can protect infants from severe RSV for subsequent pregnancies. Next slide. The work group felt that additional data are needed prior to recommending RSV vaccine during each pregnancy, or during subsequent pregnancies for those that have received a dose. The data that would be useful include antibody data in pregnant people and infants associated with vaccination during subsequent pregnancies, safety data, for example, reactogenicity data, after vaccination during subsequent pregnancies. It was felt that preterm birth data after doses in subsequent pregnancies was unlikely to be received. and that the most important safety data regarding the outcomes of preterm birth and hypertensive disorders of pregnancy would be additional safety data of the RSV vaccine during the first pregnancy as administered, such as post-marketing data being collected by the VSD, or Vaccine Safety Data Network in the United States, and data collected from other countries. Next slide. The proposed recommendations for additional RSV vaccine doses in subsequent pregnancies are essentially unchanged from last year. People who received a maternal RSV vaccine during a previous pregnancy are not recommended to receive additional doses during future pregnancies. Infants born to people who were vaccinated only during a prior pregnancy should receive nirsevimab. And these recommendations can be updated in the future if additional data are available. Next slide. And that concludes my presentation. Happy to take questions.
Any questions? Dr. Jamieson.
Thank you. Like many of you, I'm very encouraged and hopeful about this promising and preliminary intervention to prevent RSV. I have to point out as an obstetrician, though, that as is true with so many vaccines, we desperately need more safety and effectiveness data in pregnancy for this RSV vaccine. And just to clarify my comments about the safety concern, I'm also concerned, and I also want to make sure that this is a safe, want to be reassured that we are not increasing rates of preterm birth. My comment was about the precision of language. I think the precise language is there was a larger number of preterm births in the vaccinated versus the unvaccinated group, but this difference was not statistically significant. I think it's really important when we use language to make sure that we're correctly interpreting it. However, that doesn't mean that we stop looking at it. We need to continue to be really vigilant about this vaccine. And when I say that we need more data on safety and effectiveness, that includes comparison of maternal and infant strategies, data on breastfeeding, on infant protection, data on revaccination, co-administration, and then also importantly, feasibility. I was really struck with the implementation data and some of the huge barriers that we have in implementing this dual strategy. So thanks to the team for all their work.
Thank you. Fantastic comments. And I believe that gives us our last session. So Dr. Brooks, take over.
All right, thank you. Can we bring up the slides for HPV? Thank you. All right, so we will be having a vaccine, HPV vaccine work group. So, all right, so this slide shows the evolution of HPV vaccination recommendations over time in the US. So in 2006, we had a first HPV vaccine introduced. It's recommended for females aged 11 to 12 with catch-up through 26 years. And at that time, HPV vaccine was only licensed for use in females. In 2011, routine vaccine was also recommended for males at age 11 to 12 with catch-up through age 21. The difference in the upper age group catch-up was due to cost-effectiveness considerations. HPV vaccines were first licensed and recommended in a 3-dose schedule, but in 2016, the 2-dose schedule was recommended for those starting the vaccination series before age 15, update 9 through 14. In 2019, the catch-up recommendation was harmonized for all sexes, and there was also a recommendation for shared clinical decision-making through age 45. Next slide. Okay, this same slide as before, it just shows the actual vaccines. Quadrivalent vaccine was first licensed and recommended quadrivalent. Although the bivalent vaccine was available from 2010 through 2016, very little of it was used. So after the end of 2016, the manufacturers for both quadrivalent and the bivalent vaccines decided to no longer market these vaccines in the US, and only the 9-valent vaccine has been used since then. Both the bivalent and quadrivalent vaccines are available in other countries. Next slide. So this is the current routine recommendation for HPV vaccination in the US, which includes routine, catch-up, and shared clinical decision-making recommendations. Routine vaccination is recommended at age 11/12 and can be started at age 9. Catch-up vaccination is recommended through age 26, and shared clinical decision-making is recommended regarding vaccination for persons aged 17 through 45. And click, please, right. So the number of doses recommended depends on the age. The series was initiated with 2 doses recommended for those starting before the 15th birthday. Then also there's a 3-dose series for those with immunocompromising conditions. Next slide. So with that in mind, these are the topics that will be considered by the HPV vaccines work group. First, the number of doses in the recommended HPV vaccination series. Second, the wording of the age of routine vaccination. And third, guidance regarding persons in the shared clinical decision-making age range. So next slide. So we'll look at each one of these. So in terms of number of doses in the recommended HPV vaccination series, accumulating evidence on the efficacy of HPV vaccination with fewer doses. This is data that is now being accumulating over the past, I think, 6 years, maybe more. In 2022, the WHO recommended a 2-dose schedule for persons aged 9 years and older, so not down to 9, as an off-label option. A single-dose schedule can be used for those 9 to 20 years of age. So with that WHO, we are now taking a look at that ourselves. Next slide. The wording of the age for routine HPV vaccination. Some stakeholders interested in starting the vaccination at 9 years of age and want the wording to be more demanding or clear about that as opposed to a notation. Current ACIP recommendations are consistent with vaccination at age 9, but modification of the wording could allow more flexibility. Next slide. All right, and then last, guidance regarding persons in the shared clinical decision-making age range, 27 through 45. So shared clinical decision-making recommendation was made in 2019, but there is an interest in providing more guidance for exactly who would be those in shared clinical decision-making. So guidance for the subgroups in this age range. Next slide. So the work group is in the process of being formed, and the first work group meeting is planned to be next month, next month in July, with the first report from the work group coming out in October. And we will look at those first 2 questions in October on our reporting. Number of doses in the schedule and routine age recommendation wording. Next slide. Yeah, and I'd really like to thank Lori Markowitz and Carla DeSista, who we've had a number of meetings, or I think they are here. Yay, glad to have you here. And the work group members, first name of that person is Mr. Pending. I'm just joking. So our work group members are pending, but we will be forming it. It's a lot of work to form a work group, but we look forward to having this work group and reporting on these 3 topics moving forward.
Thank you, Dr. Brooks. Any quick questions? We have a couple who are trying to get planes. Okay. The committee has completed its business today. Are there any objections to recessing today's meeting? We are adjourned.